the staff, very cooperative. Today morning, you had an opportunity to see Dr. Nanjappa doing RIRS, and my friend Chandramohan is now going to demonstrate maybe in the afternoon. So here now you can see that there is a stone in the right, maybe in the pelvis. Now, if you look at this, we had a sonography film actually, and in sonography film, we had a very hydronephrotic system. So maybe it was an impacted upper uteric stone or UPJ stone, which had caused lot of significant dilation of the pelvic alyssal system. We don't have the CT scan, so I can't tell you about the HU. The stone seems to be about 1 to 1.2 centimeter in size, and they placed the stent before 1 month, so it is too much of a time. Normally, I will prefer to pre-stent in case if I pre-stent. Normally, in my practice, I don't pre-stent the patient. I pre-stent only in few conditions. I will mention those conditions. One is when I'm dealing with an anatomically abnormal kidney. That is one. Secondly, when I'm going to deal with a very large stone, where I expect that I want to be in the kidney for a longer time, and I want to put a bigger size ureteral access sheath, maybe 11, 13 or 12, 14, and I want ureteral access sheath in position, then I may put the patient, do a pre-stenting, and sometimes in a solitary kidney also I do a pre-stenting. Otherwise, 95 or 97% of my patients, I think we don't do pre-stenting. This patient stent was placed. I have a fortune of having Dr. Prashant Mulaukar to assist me today. So it's my privilege. The West Zone Secretary is assisting me, and we have got a lovely anesthesiologist team and to support us. And I hope that we can do a good job. What we have done is that because Nanjappa has already demonstrated ureteral access sheath position, placement, so we have already placed, and Prashant has already placed the ureteral access sheath in the ureter. So we will straight away go to the case. And for a change, we are going to use now a thulium fiber laser, which is a very hot topic in today's time. Nanjappa has done a lovely demonstration with holmium laser. In my practice also, I use holmium quite often, and especially for the ureteric stone, I still use a holmium laser. For the renal stone, I use now thulium fiber laser, if possible, if the stone is not much impacted to the mucosa. If the stone is free, I will go for thulium fiber laser. Today, I'm going to use a fiber dust from Conta, which is a thulium fiber laser. And we also have an IPG machine, which is again thulium fiber laser. So many of you have that IPG machine. Both the machines are more or less same. So you can make your own choice what machine you want to go for. Right now in my hospital, I'm using the fiber dust from Conta. And we are going to use a reusable limited use ureteroscope, that is a deparascope from Unique Medical, which is 7.5 French, they say. It's a 7.5 French ureteroscope, which is flexible digital ureteroscope, which is newly introduced in the market. We had a demonstration with the bioradioscope in the morning. So for a change, I'm going to show you deparascope. So you can visualize, you can have your own impression about the kind of a vision we get with this deparascope. So I think we now straight away go to the case. If you have any questions, please feel free to ask us. Thank you very much. And I'm sure that you have Dr. Lalis. I can see Dr. Lalisha and other two person. I don't know. Uh,
Dr. Pramod Rai, sir.
the
Arun Kerketa.
Okay, fine. So please ask us whatever you want to ask during this surgery, and I'll be very happy to talk to you during the surgical procedure. Okay, Lalit bhai.
Yeah, sure, sure. We'll continue talking.
Okay, fine. Thank you. So now the trolley is placed. Here you can see the trolley is arranged. The trolley goes underneath the patient's leg here, so that whenever I want to take any instrument from the trolley, I can straight away take it. So my assistant, you can see, is quite behind me. He doesn't have to be very close to me. That is one thing. So my visual cart is also in this direction. I'm facing it straight, so my spine remains the straight. If I put it like this, supposing if I keep my cart right in front of me, two, three problems. One, this Siam will come in the view. Secondly, that will hamper the movement of anesthesiologist. And third is that if I want to take any instrument, I have to completely twist myself like this. So that will produce a lot of strain on my shoulder. I don't want to do that. So I just want to be very comfortable. And while I'm operating, my axilla, this right axilla, is like this. I'm operating like this. All the movements are going to happen at the wrist level. And we all know that we basically do two movements with the right hand, right hand, and two movements with the left hand. With the left hand, I go in and out, in and out. That is one thing. And secondly, if I want to twist the scope little bit, I can twist it like this. Okay. And with the right hand, what I do is deflection up and down. And secondly, uh, rotation, medial rotation, and the lateral rotation. And it's something like this. Palm in. This is my palm. So palm in and palm out movement. These are the movements which are happening at the wrist level. So the maximum stress or strain is here, not at the shoulder. So whenever you want to go into the middle calyx, don't do it like this, you know. You don't have to do like this. You have to be relaxed like this. I support my left hand here at the stirrup while I'm operating, and I'll be standing like this. So there is no much stress because already you are wearing heavy lead apron, so that is putting your pressure on your shoulder, and there you may be wearing a lead and thyroid shield also. So you have to cause a minimum damage to your musculoskeletal system. And Nanjapa has explained today morning about the ergonomics of RIRS. For the irrigation, you have seen that gravity irrigation as well as I think he used the pump or pathfinder. In my routine practice, I don't use that. I mean, gravity irrigation is good, very good. Actually, it is the best suggested. But what I use is the extension tube. This is a 100 ml, 100 centimeter extension tube. The one end gets connected to the scope and the other end gets connected to two 20 ml syringes. You can take even a 50 ml syringes also. Okay, and Prashant is going to infuse the fluid very, very gently. He is not going to put lot of pressure while otherwise it will raise the intrarenal pressure. So he has to be very, very gentle. Whenever vision is down, in that case only he will slightly push it with little more pressure. Before you connect this thing, more important thing is that you have to connect this syringe here and empty it completely. So that you have to flush the system. So there are no air bubbles. Otherwise, to begin with, only you will introduce a lot of air bubbles. And air bubbles are causing a lot of problems during the RIRS. So this is very, very important practical tip which I'm going to demonstrate. While we'll be, you can see the ureter access sheath is in position. This is 1012 by ureter access sheath by Rocomed, which I love the most because it can accommodate reusable fiber optic FlexX2C, FlexX2, or it may be using a digital ureteroscope like FlexXC, or you can use a 7.5 French scope. Here we have opened up a new scope that is a DPRA scope. This is marketed by Unique Medical System, and I've been using this. The prototype I have used. Now I think it is available in the market, and it has got a 270-degree. Can you please move? Yeah, thank you very much. 270-degree deflection on both the sides. And during AIE also, I demonstrated one case with this diprascope, which is connected to there is a unit, dedicated unit, which like what you get with the BioRed also. There is a dedicated unit, processor we call. It can be connected like that. And can you please switch it on? So this is 7.5, they say, and that should pass easily through this 10.5 French ureter access sheath. The one point is that in this case, normally with a digital scope, you don't have to do a white balancing. But in this, you have to do a white balance. So we are going to create you can see right now, don't do the white balance at this moment. You can see that bluish tinge. And now can you please do the white balance, please? Yeah, are you not getting the endovision? Lalit bhai?
Now, endo we not seeing.
Okay. So how do we show that? आपका पीआईपी कैसा कुछ होता है कि नहीं होता है? हाँ जी, कोई बात नहीं, तब तक आप ये स्क्रीन पे दिखा दीजिए, सो वी सेव टाइम। स्क्रीन पे दिखा दीजिए। यू कैन सी दैट ब्लूइश डिस्कलरेशन नाउ। कैन यू प्लीज डू अ वाइट बैलेंस? यस, white balance please. So you can see the change in the color. Okay, can you appreciate that, Lalit bhai?
Yeah, wonderful.
Okay, fine. Now I think I'm going to put my scope in it. We have taken out, you can see that there is no guide wire here. So many times people ask us that when the guide wire is in the position, and so why do you need to backload the scope over the guide wire? It is always better to do that, but in this patient, we have taken out the guide wire just for the demonstration sake. So now my ureteral access sheet, through my ureteral access sheet, this scope is going in. Are they seeing the endovision?
Endoview we are not seeing.
Okay, please show the endovision. And you please, you have to flush. Are you getting endovision?
Yeah.
Okay, प्रशांत पानी डालना ना प्लीज, मेरे को दिखना चाहिए. ओके फाइन, डालो पानी. Now we have reached to the stone. Can you see the stone?
Yeah, we can appreciate.
And just can you please tell me how is the vision? पानी डालना रहना, दिखना चाहिए मेरे को, स्टोन तो दिखना
Vision
चाहिए.
is good.
Vision is good.
Yeah.
Okay, so there is a clot here. I think no worry about that. Now you can see the stone here, right?
Kanna bhai, one thing you said that the air bubble causes lot of problem. What problem does it cause? Number
Because
one.
then-
Number two, are you aware about anything like a blast in the kidney and the ureter, like we get in the bladder while doing a TURP?
No, we have not seen it till now
No,
in my.
not happening. Heard about it.
During the
Theoretically-
TUR, during the TUR, yes, but not during the
No, no,
RIRS.
during RIRS.
No, I have not. But I
theoretically,
think my friend Chandramohan is there in the audience. Maybe he can put his comments on that.
just want to ask, theoretically, is it a possibility or not? That
So-
is, I just want to ask.
No, I don't. I mean, I have not experienced that. I don't know about it. But
Okay.
the air bubble, because of the air bubble, sometimes you are misguided. Your laser fiber will, sometimes you feel that you are touching the stone, but you are not.
Okay.
So then you are that way you are misguided. So we are going to use. This seems to be a very soft stone actually. Can you please give me the laser fiber? So we are going to use a 200 micron laser fiber. Generally, we use 200 or 275 micron laser fiber or 265 micron laser fiber during the RIRS procedure. But when the stone is in the lower calyx, it is good to use 200 micron. And when you are demonstrating also, it is good to use a 200 micron laser fiber because then it will allow more space for the fluid to go in. So your vision will appear better and people will appreciate it much better. So we are now introducing the laser fiber. Can you please give me the laser fiber? You must have this adapter. Huh? This is very, very important. So this will allow the insertion of the laser fiber like this. And simultaneously, it will allow also the fluid to go in. So this connector is also very, very important. Sometime when I started RIRS procedure, that time the 2He adapter we were using. Now the 2He adapter, supposing if you have only one 2He adapter and it goes out of order or doesn't work, in that case probably there will be a lot of water leak because you do then lot of Indian jugaad. But I think you should have this. You can see the laser fiber coming out at 9 o'clock position. Can you see the laser fiber, Lalit bhai?
Yeah.
Okay, so
There is a question from Dr. Pramod.
Sir,
Ye-
appearance wise, not appearing like just a matrix stone.
yes, I understand. This is not a bad. This is a bad stone for the demonstration actually. But I think once we take out the upper part, maybe you will find a hard stone underneath it. So let's see that. And okay, so now you just show the laser machine. Laser machine show the settings. Can you please show the settings? Can you please show the settings, please? So here right now, what I'm going to keep is that 0.7 energy. I don't think I need that much energy also to begin with. I can keep it 0.5. Can you please keep it 0.5? 0.5 and 15 frequency, okay? Because the stone seems to be very soft. So total energy is 7.5 watt. Okay, and this is thulium fiber laser. I'm getting a lot of respiratory movement, madam. If you can bit control it. Okay. Yes, I am ready and we are ready to go. So laser on, please. Okay. पानी डालते रहना प्रशांत. हाँ. पानी डालते रहना. This looks like the upper part is the matrix stone. मेरे को वो नहीं मालूम पड़ता ललित भाई कि हर RIRS डेमोन्स्ट्रेशन मेरे को एक केस तो ऐसा मिल ही जाता है. पता नहीं क्यों ऐसा हो रहा
अपना
है.
लक है भाई.
लक है कि क्या है? पानी डालो. Demonstration के लिए, if you have a very nice stone, I think probably it is better because इसमें क्या demonstration करें?
वर्ड्स के लिए डिफिकल्ट स्टोन आता है
आई नो नेचुरली ऑफ कोर्स सेंट्रल पार्ट थोड़ा होना चाहिए, ऐसा हम लोग पॉजिटिव थिंकिंग रखते हैं अभी इधर, because matrix stone is very difficult to break, and actually you should take out all this, otherwise this might have a post-operative infection in the patient. And now this laser machine, it shows the timing. So we have just started, it is now 0.26 seconds, sorry, 26 seconds. So after we finish the procedure, we normally see that how much time, how much laser energy we have used. Now this is unfortunately a very, very bad.
थ्योरेटिकल क्वेश्चन कंदा भाई,
हाँ जी,
knowing
बिल्कुल।
that this is a metric stone,
हाँ जी,
had PCNL be a better choice?
of course, of course. Of course, I think better. You have to try to take out the entire this mug. Pani danna, please. I'll try to push the stone because I knew that I told Maurya that this is going to be a bad stone to deal with. So what I'm going to do is that because now it is not possible to produce a golden dust like what we normally produce. So I'm going to fragment, and then I think we'll try to grab the fibers with the basket and take it out, do a complete clearance. You can appreciate it. It's like you are trying to, cut the cotton, something like that. दो तीन केस जब करते हैं ना वर्कशॉप में, तो एक केस तो ऐसा मिल ही जाता है, ऐसा मेरा पर्सनल ऑब्जर्वेशन है। तो कई बार मेरे को ऐसा लगता है यार, देखो, कैन यू सी दैट, अप्रिशिएट दैट, all the cotton ball. So what I'll do is that I'll try to break it, and then I'll try to take out all the this muck with the basket. Can we have the basket ready, please? Basket ready, please. डॉक्टर मौर्य को बताएंगे तो ऐसे। हाँ, हिरेन है ना। हाँ, ओके ओके, थैंक यू, नो प्रॉब्लम। हाँ, कोई भी चलेगा, जीपो चलेगा। जीपो इज फ्रॉम बायोरेड, नाइस basket is like a jaw, it opens like a jaw, unlike the flower kind of a basket. So I'll try to, because it will be easy to grab these fragments, no problem. Now let us demonstrate that basketing, okay? I think that will be best. Stand by, please. Now, basket दीजिए please. बंद करिए basket, please. So when you insert, the basket has to be in a closed position, otherwise it will break immediately. This is 1.9 French Jeepo basket by BioRed.
Kandap sir,
हाँ जी,
IndoView is on. We are seeing on IndoView Vision. In the meanwhile, we are starting lecture of Dr. Khadgi sir.
हाँ करो करो, कोई प्रॉब्लम नहीं,
Okay,
वैसे भी कुछ दिखाने को है नहीं।
कंटिन्यू करो।
Sir, we
Dr. Khadgi,
invite
sir.
Dr. Sanjay Khadki sir
Yes,
for
Sanjay,
his
please.
talk on supracostal puncture in mini PCNL. And Dr. Sanjay Khadki sir is not new for any stone surgery. He is well known, renowned
पानी डालो।
surgeon. He is from Nepal. Welcome sir.
चलो ओपन कर बास्केट, ग्रैब।
Good afternoon to chairpersons and friends. Once again, thank you very much for this opportunity to perform live surgery and for the presentation. And today I'm going to talk about the supracostal punctures in mini PCNL. Well, it may be supra 12 or supra 11, and people have fear of doing supracostal punctures because of its high rate of chest complication, basically. And these complications may be more pain after the PCNL or hydrothorax in 13 to 15%, intercostal vessel injury in 1% of the cases, and hemothorax in 2%. And this may vary from person to person and surgeon to surgeon. And if you see these, some of the comparison of supracostal and infracostal approaches, hydrothorax was found in 26 patients, that is 15.3% of the group and 1.4 of group 2. Only 9 patients, that means 5.3% in group 1 needed intercostal drainage. That means not all the people need this supracostal drainage. Most of the time, even the uh, pleural effusion, they subside as within 1 to 2 weeks of time. If patient do not have much complication, no fever, no cough and all, we just observe closely and usually they subside after time of 1 to 2 weeks. So this is another paper, a retrospective review of treatment, safety and efficacy, and there was a 3% thoracic complication rate with upper pole punctures and overall complication rate of 30% for both thoracic and non-thoracic complications. But I have a different result, which I am going to share with you today about the chest complication when we go through the supracostal punctures. So supracostal punctures in supine PCNL are safe, and this was a study by Dr. Wood and group. The major complication rate was 16.3% in prone group versus 3.6% in the supine group. I'm not very sure about this paper, whether this prone position really have a higher incidence of pleural complication. And coming to the 10th and 11th costal puncture, overall complication rate is again 30.9% in group 1, that is supra 12, and 28.2% in group 2. So when we go through the lower pole, there is always a high chance of, that means 6.9% had a retrorenal colon, of which 18 means 4.6% were on the left side and 1% on the right side. So colonic perforation complication was seen only in 2 patients, that is, the rate was 0.3% only. So this is another paper cross data on the in PCNL. If you see the upper pole axis group have more stagnant stones, which if you see the complication rate, that is about 5.8, almost 6%. And this is very interesting paper by Professor Lee from Beijing, who does everything under ultrasound. He does not use fluoroscopy. If you see his paper, about 0.19% patient had pleural injury. So about the CT scan post-operatively in this supracostal punctures, if you note that thoracic complication are noted in 58.4%. CT scan does not alter management protocol. In majority of cases, most of patients get managed conservatively. So there was a paper also noted the nephropleural fistula after supracostal puncture PCNL. Well, if you see my paper, this was published in 2019. In our cases, about 80% of the cases, we go through either supra 12 or supra 11 punctures. And our overall complication rate is 8%, out of which 7% fall in Clavin 1 and 2. Major complication is only about 1%. So this is the pleural refraction. If you see, which pleura runs from middle and takes mid after rib and goes lateral, and generally, as I demonstrated in the morning, our puncture is somewhere between here, between 12 and 11. Even if I have to go to supra 11, I prefer to make more lateral puncture in order to avoid these pleural complications. So the advantage, as I have shown, it is always convenient to work for the surgeon, which forms a shortest track to the kidney, and it works as a neutral position for the telescope, which we can swing up and down without much difficulty. Well, as already demonstrated this, our preference is more lateral puncture under the fluoroscopy. This is supra 12. We just try to hit the fornix of the calyx most of the time. And when we can get the access just through the fornix of the calyx, we don't see much bleeding. And when we have a lateral puncture, more lateral puncture, and we can get the horizontal tract, which is when we have a horizontal tract, then stone evacuation is much more easier. But when we have a more middle puncture and stone track is more vertical, stone evacuation is more difficult. So this is again is supra 12 and supra 11. About 10 to 15 of the percent of the cases we go between 10th and 11th. However, more lateral, and we do not see much chest complication when we make a more lateral punctures. So we generally dilate up to 18 French in most of the cases, maybe because of the small tract too. Pleural complication is much less. And when we get the horizontal tract, even after stone disintegration, stone evacuation, even with the retrograde saline push, comes out very easily, as you can see here. Uh, this makes much easier. And we usually do not need the suction devices when we get the axis more horizontal in mini PCNL technique. And this all three punctures are supracostal, which demonstrates if you go more medial, the track will be more vertical, as I already mentioned. And if you come more lateral, this will be around somewhere around 45 to 60 degree with the sagittal plane. But if you go with the 10th and 11th, it becomes almost in one plane. And in mini PCNL, which makes more easier to evacuate the stone. So the advantages of supracostal to mid-calyx is it has a high accessibility, high maneuverability, and less pain as we do tubeless mini PCNL, and less additional tracts because of its high maneuverability, and of course, obviously less bleeding due to smaller tract and high stone clearance rate. So this is just one video entering through middle calyx supracostal puncture, how it acts when we go through the mid calyx, and we can swing our scope in mild hydronephrotic kidney. It has a high maneuverability and which minimizes multiple tracts. Not only that, when we go through the middle calyx, we can also advance this telescope up to the L4, L5 level. Even for the upper ureteric stone, more than 10 millimeter stone, I prefer to do mini PCNL in order to achieve high stone clearance in single sitting procedure. So when you go through the lower calyx puncture, infracostal, it gives insufficient access for the complete stone clearance. Access to upper calyceal is restricted. Chances of vessel injury is high. Difficult to place double J, and working position for the surgeon is uncomfortable. So I conclude my talk that our main primary objective is patient safety, stone clearance rate, and post-op morbidity. Choose the one which has been claimed to be safest, causing less harm to the patient. More than 80% of cases go to the supracostal. Yes, stone clearance rate, more than 95% without much undesirable complication. It is completely safe if we make precise and more lateral supracostal punctures. Thank you very much.
Wonderful. Thank you, Dr. Khadki, for an excellent presentation. Any question? Yeah, please.
Usually, if we have a hydrocalyx, most of the time I choose the hydrocalyx one. That means if we enter from that calyx, that means there is some obstruction in front of that. Usually I do not much bother about the anterior or posterior. With the small caliber of scope, we can advance to different calyx without much difficulty.
Sanjay,
Yes.
one concern I had was if you have so much fluid in the chest, why would we not put an ICD? Why would we want to wait for spontaneous
No,
resolution?
if
Aren't you worried
patient is
about scarring, adhesions?
No, we closely monitor this patient. If he's not complaining of anything, we see whether he has having a fever, cough, or saturation is dropping. Only then we keep. Otherwise, for 1 week, we just advise for chest physiotherapy, advise them to take a long breath for 1 week. Usually that works many of the times.
We prefer to put an ICD, to be honest.
It's no problem. Yes. Thank you very much.
Thank you. Thank you very much.
Thank you. Thank you.
Dr. Yogen, momento, please. Yeah. Dr. Chandra, please. Dr. Khadki and Dr. Chandra, please come on the stage. Thank you.
ललित भाई पानी पानी डालो.
Yes, Kanda bhai.
या देखो अभी इसके अंदर से स्टोन निकला है, देखा? ये मक है, मक के नीचे देखो, दिस इज हार्ड स्टोन.
समुद्र से मोती निकाले हो भाई.
हाँ भाई, निकालना पड़ेगा ना, दिया है काम ऐसा तो.
Continue, please. We are seeing you.
आई एम श्योर दैट यू आर टेकिंग लंच ऑल्सो नाउ एट दिस मोमेंट. Anidano. Because of the muck, I think the vision is not that great because it is coming on my way and I'm unable to break it completely. Well, it's a gradual job. We could have converted this stone into PCNL also, but as we have anesthetized the patient and we have maybe made a promise to do RIRS for this patient, so we are finishing the procedure. Anidano, please.
Kandar,
Ji.
can you show us how much muck you have taken out so far?
Yeah. Can you show this camera, please? यहाँ पे दिखाओ, ये भी दिखाओ और वो भी दिखाओ. ये कैमरामैन तो गुम हो गया, वो भी खाने के लिए चला गया.
Yeah, I can see that, Prashant. Thanks.
Here. You can see here. There is lot of muck here.
Still more inside.
Yeah,
Lots more.
still more inside, and then there is a stone. Now we have found out a stone here.
Right.
So we'll try to deal with the stone. You can see now the stone, okay?
Yeah.
So that we are going to. But
Kandar, we were talking about urine culture. I'm sure this culture must have been very positive.
I'm sure. But I think they said that the culture is negative. That's what Dr. Maurya informed me. Because I asked the first question to him that when was the stent placed? And secondly, when was the urine culture done? He said that urine culture is negative, sir.
What's your choice of antibiotic in this patient?
Right now, I mean, in all patients in my hospital, we give 1 day, but till when the patient is in the OT, sorry, in the hospital for 1 day, we normally give cefepime tazobactam injection at 12 hourly, and then discharge the patient with fluoxacin with maybe ofloxacillin or ciprofloxacillin. That's what we normally do. In this patient, probably he will require again a repeat urine culture. And secondly, maybe we should continue with the injectable medication because mm, no, it looks very bad. Here the picture is also not that
Sir,
friendly.
can we place a feeding tube through the sheath and suck some amount of mug so
Yeah,
that
we
it will?
tried it once while you were talking to Sanjay. I mean, while Sanjay was giving his talk, we tried it once, and that's the reason we could see the stone now.
Yes.
Otherwise, it was difficult to locate this stone also. And you can see that there is lot of mug which is by the side coming out through the ureteral access sheath. Every moment is lot of mug. Without doing anything also, this mug is coming out.
Just for the theoretical discussion, will it be a good idea to go ahead and do a PCN in this case?
Yeah. That's correct. Absolutely. Ma'am, I agree with you. But this, supposing this patient has been promised RIRS, and if the patient is not ready for PCNL, yes, already patient is anesthetized and we found out the stone. So I thought that probably will finish. Otherwise, Kamlesh Maurya can later on consider doing a PCNL. But I promise you that this part we will clear. Maybe it will take little more time than I expected because I have to be very careful that I don't damage the mucosa because the vision is constantly hampered by that mug. And I'm sure that you must be appreciating that also, that kind of a difficulty faced by me. So I have to be very balanced in my whatever I do.
Sir, the only thing which could have helped better was some suction, which you hope that it will come in 1 2 months.
Yes, probably. Yes, we tried to even suck that, by the way, through the scope. We tried to suck. Dr. Hiren Soda is with me. He also suggested me some maneuvers. Uh, we partly got succeeded into it, but not much.
Sir, if you can push the excess sheath there and then apply suction
Okay.
through the excess sheath,
Okay, I'll
maybe
show you
it
the
will help you.
show the CM. Can you see the CM now?
No, we can't.
No, we can't.
Show the CM, please. I have already done that. My access sheet is right at the stone. That also I tried. You can see the show the. You can see that.
Yeah.
Yeah.
So there are two screens. One screen you can see a large stone with the access sheet in place. Okay, on
Right.
your left.
Yeah.
Correct.
On your right now, it is a present view. You can see that the size of the stone is diminished, and the ureteral access sheet is right there, and you can see the tip of the scope. But the stone size is diminished. Can you appreciate in both the film?
Yeah, we can.
Okay,
We can
fine.
very well
So
appreciate.
that is what we did, and that is the reason we are directly sucking the muck. The muck is constantly coming. Can you please show here, please? It is constantly coming out through the ureteral access sheath. You can see a lot of muck here. Can you? Can you?
Yeah, we can.
You can see
We
this
can
muck.
appreciate that.
Yeah, so it is directly draining without doing anything. I did that part also. My ureteral access sheath is sitting right next to the stone, which
Right.
normally I don't put beyond the UPJ. But in this patient, because so when we were taking out with the basket, I had to travel the entire length of the almost 3 4 centimeter of the ureter, which to avoid that, I can directly put the ureteral access sheath next to the stone so that whatever I fragment immediately I grab and take out. So I don't have to do a procedure of introducing my scope every time through the upper ureter. You can see all this now stone dust. I think I'll fragment it now very fast now.
Sir, we have different lengths of excess sheath. The length you prefer?
This patient we are using 35 centimeter. Can you पानी डालना जरा please क्योंकि vision इतना अच्छा नहीं है. We are using a 35 centimeter ureteral access sheath, which is my preference in almost every patient. But if the
Even
patient
in males.
even in males, but if the patient is very tall, in that case we use 45 centimeter. 55 centimeter I used abroad, not in India. When the patient is very tall, we have used 55 centimeter. And usual the width of the caliber of the ureteral exercise which I use is 10 French. हाँ गौरांग सर को जाओ ना, गौरांग सर के पास कोई प्रॉब्लम नहीं है ना. Dr. Lalit Bhai,
Yeah.
Gaurang is ready with in the operation theater. So if you wish
Yeah.
wish to go to
Can
him,
you shift to the Dr. Gaurang's theater?
I will come back to you once I am
Yeah, yeah, yeah.
slightly done. Because there is nothing much to show in this case actually. હું એ જ કરું છું પણ જગ્યા નથી. હા हाँ ठीक है चलो.
Sir, every time we give you something special, I think.
Every time, yes, you remember. Anyway, but I think that is what I need actually. Now, can you give me the ureteric catheter? इस हाँ इससे भी वॉश दे सकते हैं ना, इसमें क्या प्रॉब्लम है? You can give the wash with this also. Can you give the wash
अभी
please?
मॉडरेटर में कौन कौन है? कमलेश?
Yeah.
Yes.
Yeah, we are
Good
with you.
afternoon. I am audible?
Yeah, you are audible. But
Yeah.
if you speak little loudly, it will be better.
Okay, I will speak loudly. Okay.
Okay.
Who are the
Though I know that
moderators?
this is lunch time, you have not eaten your lunch, but still.
See, it is important that you also have not taken a lunch.
Yeah,
so that you can hear with
But-
a low voice also.
Yeah.
I am thankful to the West Zone Urological Society, Chhattisgarh Urological Society and Kamlesh for giving me this opportunity, and I special thanks to Prashant also because he insisted that you demonstrate this digital nephroscope which is having a multi-channel. So, and I am thankful to Shweta and Faith for giving a wonderful anesthesia and managing the whole scenario extremely well. Plus, I am thankful to Rahul who is with me to support, and all the cameramen and everything. Hold it. Now coming to the instrument set, the case is described or is yet to be described?
We can
Okay.
see the X-ray.
We can see the X-ray.
It's self-explanatory.
So the X-rays, if you see, I have seen the CT scan picture. The renal parenchyma extremely thin. So I am expecting. Can you reduce the exposure? It is very high. It's all white. Can you reduce the KV? KV come karo, because it is all white, getting white out. Yes. This. Can you see now? This is very important to have an exact exposure of the KV and MA. That would give you a much clearer details. Now you can see that there are multiple stones in the lower calyx. The pelvis stone is big and impacted, and upper calyx is big, roomy. And the CT scan suggests that it is a very narrow, very thin wall. So I expect that there might be an intussusception of the renal parenchyma when I am dilating. This is especially true when I am doing a single step dilatation. So I will use a telescopic dilator so that it is a gradual dilatation, right? Now
Okay. All right.
coming to the armamentarium, this is a superpuck sheath set. Now there are 4 different sizes, which is autoclavable version, and if you attach, this is a suction master. So the nephroscope goes from here, the suction tube goes from here, and when I close this, the suction is activated, and when I keep it open, suction is not activated, right?
Yeah.
Depending upon the size of the stone, we want to make a track. I am planning to make a 21 French track so that the procedures can be faster and fragments can be removed early. Now, one of the most important thing which I am going to show today is a digital nephroscope. Can you see here? Can you see this?
Yes.
Yeah.
Yes, sir.
Yeah. This is the digital nephroscope. Here an irrigation. Can you give me the irrigation? This is transmitting the light and carrying the image. Now, can you see here? Can you focus here? There are two channels. One is a main channel, and there are another space through which the fluid will come out. Now, this is a 16 French. Give me 5 French forceps. So, when I am putting this forceps, it is coming from the channel. So, whenever the forceps is there, it does not increase or decrease the fluid, which is very important in PCNL, because when we insert the flow instrument, the fluid goes down, right? So this is now taken care of. Now we can have a different sizes of scope. We can have a smaller length, bigger length, whatever length we want, right? Another version which we are planning to come out, I request everyone to see and give us a feedback. Now this is another type of nephroscope design. There are 3 different channels. One is coming from this side, one is coming from other side, and so when we use a laser fiber here and attach a suction here, so full this channel is available for suction continuously. So this becomes a laser suction nephroscope without adding anything inside. So from here the fluid can go, from here also the fluid can go. Adapter. બીજું બાકી છે ઇનમે ત્યાંથી લેવાનું બાકી છે. The way we are using for a flexible ureteroscope, we can attach here, and from lower down we can allow the fluid to go in. So this becomes a channel for laser fiber, this becomes a channel for sucking the fragment, and this becomes a channel for allowing the fluid to go in. And the amount of fluid is so much that you don't have to raise the height of the irrigation fluid, right? So this can come in different sizes. We are planning to have one is 11 French, 13.5, 16 and 19. So depending upon the size of the track and size of the, but the vision would be the same in all sizes of nephroscope. It's not that when you have a smaller size nephroscope, vision is smaller. When you have a bigger, the vision is same, right? So whenever you think there is anything to be added, you just give me a feedback, because it is very important. We are an important stage where we come out with something different. So far in PCNL, we had focused on the sheet.
सर सक्शन चैनल जो है आपका कितने फ्रेंच का है सर?
Pardon?
सक्शन चैनल जो है वो कितने फ्रेंच का है?
वो 13.5, उसके अंदर 4.2 French is a separate channel, and rest 2 are a channel for irrigation. And this irrigation is very powerful. In this 16, the central channel is 6 French. So 5 French instruments can go very easily without any hassle. And 1.5 mm pneumatic probe also can go without any hassle, right? So this is about the instrument.
Sir, in your section, laser section instrument, can we use pneumatic lithoclast?
Through here, we can use a pneumatic also.
Yes, yes.
Because this is a straight channel, we can use a pneumatic, and one can be used for, then the sheet is also having a suction, you don't need to have anything else. So this is possible to have a direct suction, and a pneumatic also can be used. Only thing you have to change when you are using and add a suction, so it would act as a suction cannula. You don't have to put a suction tube into the nephroscope. It's already there, it has no other connection. So this can work as a suction tube also.
Sir, right? What is the cost of your scope, sir?
It is under process.
Okay.
Thank you. So now coming to the case, I'll put a today is a case where I can go through the lower calyx, I can go through the upper calyx. So I will be demonstrating air pyelogram and an upper calyxal puncture, because upper calyx is so roomy that if I go from lower calyx, there is a possibility of a fragment going into the upper calyx, and we might have to add another puncture. So to demonstrate an upper calyxal puncture, another series, empty. Right, I am putting now, because I have attached the infant feeding tube here, I am able to inject under my control, right? Foot switch is also under my control. Now I am injecting in air. Can you see the air coming? Hello?
Yeah.
Have you seen that air?
Yes. Yeah. We can.
Okay. So I don't need to add anything else. Now I'll take a needle. So this is the calyx which I want to puncture, right? So this is likely to be an intercostal puncture. Now 30 degree CM. मेरी तरफ. Can you see it is moving? Now it has gone slightly above 12, above 11 rib, right? You can give it complete 30 degree or 20 degree, doesn't matter. Can you see my needle? Now I am advancing like a bull. Straight, straight, 0 degree, 0 degree. Right? Can you inject fluid or water? Yeah, inject the water. Check out. 3 hours. Yes, I had gone slightly in, right? Can you see it now coming very clearly?
Yeah, we can.
It's slightly turbid also. If you notice, it is not a clear. You keep pushing. Have you noticed this? It's not a clear fluid. It's a turbid fluid, right?
Yeah.
But-
Had you any difficulty due to the thin renal parenchyma, or it was just like a usual one?
Now, I could feel that I had punctured the parenchyma, but because nothing was coming out, I slightly pushed in, and that's the reason. Give me a guide wire. I could feel that I had punctured the parenchyma. Now, see, whenever I am holding a needle, these two finger is stabilizing my hand, and this finger and index finger is allowing me to. Can you see it?
Yeah, we can see.
I'll try to again withdraw and try to see if it can go. It's not coming out. So if I'll try to bring out, as Dr. Khadge had said, it might create a problem. So I am not removing the guide wire and I am dilating, right?
Yeah.
I'll use Alkin's cannula with needle, right? Alkin's
go ahead.
dilator.
Go ahead.
Hello, Lalit bhai, can I take your 1 minute?
Yeah, please.
Okay, so now just look at the situation. Can you please show, where is the cameraman, man? We will show you the pre-operative picture, and this is the.
We are not able to see. Just 1 minute.
I'll show you. Just show the Siam picture, please. Yeah, so you can see, come here. You can see the Siam here.
Yeah, we can.
Now there is a stone here, there is an extra sheath here. This was a pre-procedure, the pre-operative.
Yes.
And right now we are here. So
Okay.
stone we have tried to dust as much as possible, but there is still lot of muck inside that
Okay.
we could not take out. Now, so what we are doing is that we are putting a double chest tent and coming out. Kamlesh, because of the paucity of the time, I think we don't want to proceed further. And secondly, it wouldn't be possible to take out this entire muck also. So what is the plan is that we might put a small puncture and take out and finish the job, but not today. Kamlesh will do it maybe in a day or two, maybe after 2 days. Today,
Okay.
because we have too many cases to go.
Yeah. Okay. Good.
Okay.
Wonderful.
Yeah. Thank you so
Very,
much.
very good. Great job.
Nothing great actually.
Yeah,
Anyway.
difficult case. The best possible has been done, though it may not be good enough, but it was the best possible.
Okay. Anyway, in the afternoon, I'll try to demonstrate some good dusting. Let me see the case now because I need to select a proper case now. Thank you so much. Thank you so much.
Welcome. Very nice. Thank you.
Retrospectively,
Gandhar, select a difficult one, please.
What can I say?
Shifting back. Thank you,
retros-
Gandha bhai. We are shifting back.
retrospectively,
Yeah.
if you realize, should we have converted it in the beginning itself?
Correct, correct.
Yeah, yeah. Gandhar, that's what I wanted to ask. Thank you
Thank
so
you.
much. Thank you.
We are with you
Guide
back,
road.
Dr. Kaushik.
Yes,
We are with you back.
yeah. So I had put an alkenes cannula. Hello.
Yes, sir.
The primary purpose is that I want to do a stepwise dilatation and not losing the track, right?
Right, sir.
So the alkenes cannula, I had put it and now I'm putting a guide rod. Right?
Yes, sir.
Now I am holding here at the guide rod, junction of the guide rod and guide wire so that it does not come out. Right?
Yes, sir.
Now I am taking it out and again holding it back so that the fiber doesn't come out. And now I am using a telescopic dilator. Keep adding. I'll dilate up to 21 French and then taking out all, and then I'll put my Superpoc 21 French sheath. अच्छा हाँ उसके अंदर दो है वो क्या लगा दिया है नहीं निकलेगा अभी ओके हाँ कोई बात नहीं अंदर डाल दो लेट्स सी कोई बात नहीं अभी कुछ नहीं कर सकते वी डोंट वांट टू वेस्ट टाइम वो डाल दो ना कोई बात नहीं अंदर ही गया ना नहीं टाइम पकड़ कर दो चल आगे कोई बात नहीं हाँ डाल दो हाँ तो ये 9 and 12 French dilator are by mistakenly jam. Doesn't matter. It has gone and reached up to the right.
Yes, sir.
Can you see there was a slight jerk because I just came out of the capsule. So I need to be very careful that next I am in the system. Keep injecting now. I should not push so much, right? But there is a lag in the CM. Keep pushing. Can you see the fluid coming out? Here. This is how much?
Kaushik sir,
Yes.
we and Lalit sir and Arun sir are leaving, and Dr. Ajay Prasar and Dr. Subhasis Mandal will take.
Okay. So there is a change of guard.
Yes. At this end, not at that end.
Okay.
1 minute.
Uh,
Amendment. Jackie sir.
continuing to dilate, right? This is like any standard dilator. 21.
Dr. Rajesh Soni, please come onto the stage
Yes.
to give the memento to Dr. Lalit Shah, Pramod Rai, and Dr. Arun.
You are able to see the CM picture and surface?
Yeah, we are able to do.
Okay, so we are continuing, right? Now I
Yeah.
21 कौन? ये कौन सा था? हाँ, तो I am taking out all these dilators now.
Thank you so much.
Now give me this 21. What was it? I didn't want your hand to expose. As far as possible, we should avoid exposure. Not only yourself, your all assistants. They are also important part of your team. Now I had put this. Now I'll take out the, see this dilator which we have designed, sheath is with a dilator. So the last dilatation and everything becomes one step. Now can you see the sheath on the surface?
Yes.
Now I'll take out the guide rod. Can you hold this so that the guide wire doesn't come out?
Are you happy with the position of guide wire?
In a way, yes, in a way, no. Why I am happy? Because if you coil too much of a guide wire, the telescopic dilatation will not occur. Because the whole sphere would become completely coalesced and dilatation can become extremely difficult. So you should not coil the guide wire excessively in a narrow calyx. Expose. Right?
Stone
Now-
load.
Now I am using it. Hold it. See. Don't. Now I am using my digital nephroscope. मैंने निकाला कोई बात नहीं. One.
Stone load seems to be more. Are you happy with the puncture?
नजदीक. I am happy with the puncture. नजदीक लो बहुत नजदीक लो. Now are you getting the picture?
Yeah. We are getting.
Picture.
We are getting the image as well as the outside camera.
Now can you see the sheath? Now
Endo view, please.
endo view. Can you see the whole calyx?
No.
Can you see the endo picture?
No, it's
Not now.
Give the endo. आप लोग बदलिए आप ऊपर से. ये चेंज कर रहे हैं आप लोग.
Yeah.
Yes. Now I am attaching the connector so that whatever the fragments are there, if I want to suck, I can suck. There is a separate suction machine which is a low power and has a bottle which can empty with a change of a button. Now I am starting. How is the vision? Can you see?
Yes.
Now,
Vision is good.
now because I had start suction, this is coming.
What size stones?
Can you
this?
see the suction effect? Now the moment I started suction, which was in the lumen, it has came out, and now I am going in to suck another fragment. It has come out. Can you see?
Yeah.
It has gone by the side, right? So this is how the suction is. Or whenever you want to advance the sheath, you should bring out the nephroscope in the sheath and advance under vision, right? Because I am not right now putting my finger here, the system is not collapsed. Can you notice this? And
Yes.
if I put a finger, the system has collapsed, right?
Yes.
Can you see?
Okay.
So now I need to find out where the stone is entering into the calyx, because this is can you take out the CM? पीछे कर लो, हाँ. Right now I'll have to find out my ureteric catheter also, because that would give me a guide.
From the
Can you see now?
Yes.
Now because of the suction, automatically the fragment comes in. I don't have to search the things. Now I am here. I'll advance the sheath through that infundibulum. Right? Now I
Yes.
have an option to see. You should not advance the sheath when you are like this. You should not advance the sheath. When you want to advance, withdraw the scope and then advance the sheath. This is very important. Do realize the advantage of this sheath. It is coming out of its own. All the debris is coming of its own.
Yeah.
Right?
Yes.
Now I'll go from here, and what do you want me to use, pneumatic or a laser?
See, this
anything which is fast.
stone is large, so
Pneumatic will
Give
be
me
better.
pneumatic.
yeah.
Your reasoning told me that you want me to use a pneumatic, right?
It will be
It's
faster
your,
when
it's your
It would be
choice also,
faster. Huh.
and whichever
Give
way
me
you
a
are
pneumatic.
comfortable.
Ready? Now, see, because it's a separate channel, give me a foot switch. Come on this side. Hello. You can come on this side. You'll be able to see better, and you'll be able to hold also. And sister, you can come on this side and just hold the sheath, right? Now, where is my foot switch? Can you see? I had put my scope, but the vision is not hampered anytime.
Yes.
You can reduce the height of the irrigation. Reduce the height of irrigation. I don't need. And I don't put this. Don't put a pump. You take it out that pump. I don't need a pump at all. Take it out that pump. I don't want infection to aggravate by hard pump. Now, where is my foot switch? Pneumatic.
Are you feeling any difficulty in approaching the stone? Because
No.
I think there's a lot of buckling in your nephroscope.
No, it will not buckle. Now I am using pneumatic. Now, how to use a pneumatic? I know people have used from last 30 years, but you just hold and allow it to break rather than pushing the stone like this. Don't do this, because it would create a pressure on the opposite wall of the pelvis, and there is a perforation. So I am just holding, and it would work faster than the laser, and the effect would be same as laser. Can you see?
Yes.
The effect is almost the same like a laser, but much faster, much cheaper, without opposite wall pressure.
What is your objective? You want to break stones into pieces, or you want to?
It would break into the pieces, but you don't need to push. Otherwise, the opposite wall, there would be a lot of ecchymosis at the end of a surgery.
What are
See, the moment, see, it has started pouring, right?
Yes. So what are the settings of your pneumatic lithoclass?
I have not noticed. Can you tell me the setting? See, I am just putting, and it is working like this.
Kaushik sir, Prashant here.
Yes.
Just wanted to reconfirm what was the
Now,
size.
can you see the fragment that is broken?
Yeah. My question to you was, what is this? I forgot. What was the size of this external diameter of the sheath?
Sheath ID is 16 French.
Hmm.
16 French is an ID
Hmm.
of the nephroscope, and I had used 21 French the sheet size.
Sheet size is 21.
Right? 21 is inside the sheet size. Now when I am going, I'll try to go closer with the sheet. Give me pneumatic. So they are coming because of some effect, and I am putting a finger to pull it out.
And the vision is very good.
Thank you very much. This is what I want. The ergonomics is so easy because there is no light source, no camera head, and the vision is excellent. And the same vision would be available if you use a 13-frame nephroscope or a 19-frame nephroscope. Now, see, it is breaking. I can't say that fragmentation will not occur, but we don't need to do a dusting. We just need to safeguard the opposite pelvic wall.
Kaushik sir, what is the durability of your scope, this scope, which you are using?
Right now we don't know, but there is nothing that can go wrong as long as LED and chip is working. It will go on and on. I am using from last few months.
How
I
many
have
cases
done
you have
ureteric catheterization, stent removal, and block resection after inspiration from Dr. Chandramohan, and I had done with this scope only because the laser is very stable.
Since you have done whole from this scope.
Yeah. You see, I am not pushing the pneumatic at all.
Yes, sir. Yes, sir.
The most important thing.
You are just supporting it. Yeah.
And practically there is no damage to the pelvic wall. The fluid is clear. I had a great temptation to say, okay, let's use, but after seeing the
And which
irrigating
which
fluid
company?
coming as a
Yes, sir.
slightly turbid, I wanted let it be a complete clearance on table, no dusting, nothing. And the time should also be less.
Kaushik sir,
Can
what
you
is?
see how easy it is for me to withdraw the nephroscope?
Yes, sir.
Yeah.
Yes, sir. So what is the means pressure you are keeping on your suction? What is the negative pressure?
What is the pressure? 150 millimeter, 150 centimeter of
Minus
150 millimeter of mercury. Can you change the irrigation? If you notice, even the fluid movement which was going, we were able to notice. Now I want to advance into the infundibulum, but that has to be done under vision, right?
Yes.
So now give me the pneumatic. If you see on the table, I need a minimal instrumentation. Ergonomically is very easy. I just hold, I even don't hold, I just guide the probe. Dr. Prashant,
Yes, sir. Yes, sir.
how are you?
Perfectly fine, sir. Enjoying your procedure, surgery.
Yeah. I do not want to bluntly use the pneumatic to the opposite because I may not be able to see through this. So I am into.
Are you simultaneously giving irrigation from the ureteric catheter or no?
ऊपर पकड़ी लो ना ये बांधा नहीं है above the breast कमर के ऊपर बांधो और टाइट करो. Can you see I have to withdraw up to here only?
Yeah.
Then yeah, I can go in again because the fragment falls. See, without doing anything, that fragment that came, I had not activated even suction also.
Can you show us the suction? Because there is a chamber where the stones get collected.
Hello, surface view, suction. Now, can you show the suction machine? bring it towards this side. Take slightly away. Oh, एक minute. Let it be there and show the change the camera head. Chinmay. So what he wants to. Okay. So see here the stones are getting collected. Can you see this bottle?
Yeah.
Hello.
Yes, yes.
So here the fragments are coming, right?
Yes.
All are fragmenting getting collected here. And the best part is that this comes in the center of the picture. My pneumatic comes from anywhere, but it will enter from 6 o'clock and reaches to the center of the picture, right?
Yes.
That's the beauty of the design of the channel. Now I'll need to break this. So this 16 French scope can work for any, because you don't need a bigger pneumatic probe to break the stone, right?
Yes.
See, what I am trying to do is that I keep removing the fragments if it is coming out, so that at the end I don't have to search here and there.
So you are not using suction all the time?
Whenever I feel that the stone is not coming, I put my finger here. Otherwise, I am not using. Minimal suction is always going on. Minimal suction is always going on. But if I want to add the suction power, I close this. Can you see these fragments are coming?
Yes.
So I am not putting my finger. But if it is falling back, I'll put my finger. So I have a full control on the suction power that is being used. Multiple fragments are coming.
And what is the irrigation pressure?
Reduce the height still further. There is no pressure irrigation, and we cannot reduce the height further. Reduce the height further.
So
Otherwise, you can reduce the.
adjusting the height of irrigation fluid.
Wait a minute. I'll show you with this height. Can you see the height?
No.
Height of the irrigation.
No.
So this bottle gradually. Can you see this height of irrigation?
Yes.
And then now you see here what is the amount of fluid that is coming. Do you realize?
Yes, yes.
With the instrument channel that is separate, you are getting this much flow without any pressure. I want even slightly lower irrigation, but we are not able to reduce the height of the irrigating stand. They had put a pressure device, BP suction, BP bulb to increase the pressure. I told him, you take it out. Show me that piece what you have applied there. So there. They put it there. I said, you take it out. Can you see this?
Yes, yes.
So I told you, we don't need this, and you take it out.
It's just gravitational.
Yes, just gravitational. That's all. And I see the fragments are coming back. In a collapsed system or a thin renal parenchyma hydronephrotic, mini-pug whirlpool effect, the vacuum cleaner effect is usually not occurring because it keeps floating inside and inside. So this active suction is allowing all the stones to come out. Now give me pneumatic. I need to break this stone.
And this clear vision will always be there in spite of inflamed system.
Pardon?
If the system is inflamed from inside, the vision remains same or there is some haze?
It depends on the mucosal edema.
Yeah.
If it is edema, it will show up. If it is, but it would not aggravate the edema because I am not adding any pressure. I am not allowing my pneumatic energy to be transmitted to the mucosa. See, what we have faced many times, that if you use a pneumatic on a thin parenchyma, it perforates. If you are using a pneumatic in a calyx, the calyxal mucosa gets damaged because there is nothing like a mucosa. It's a very thin mucosa as against pelvic mucosa. So I try to avoid the pneumatic in a thin parenchyma and in the calyx. If the stone is sitting in the calyx, I avoid pneumatic in a calyx. Either I bring the stone into the renal pelvis or I use the laser.
Okay. Are there secondary stones also?
There are secondary stone in the lower calyx. So from upper calyx, I'll be able to reach there. Once I remove that renal pelvic stone, I'll be able to see that. Previous stenting has helped a lot in increasing that. My only request to Kamlesh was that give me a stone where there is minimal infection or no infection. And he did a wonderful job of giving a good case.
And it is a nice demonstration also.
Thank you. I had shown the supracostal puncture. I had shown the air pyelogram without using any contrast. I have shown digital nephroscope. I have shown the Superbox sheath. So in one demonstration, I tried to show as much as possible. Now I am able to enter through the infundibulum into the renal pelvis, right?
Yes.
I had not forced. I just waited, change. See, pushing is not required. Don't try to corner the stone with a pneumatic. I am repeating again and again because it is completely unconventional thing for people to do. They try to push the stone with a pneumatic. वो आ रहा है ना, अपने आप आ रहा है. Can you see when I am going in and coming out or going in, those fragments are waiting to come out. Pneumatic.
So by any chance, could this be a stone due to POJ obstruction?
Pardon?
Could there be associated POJ obstruction?
I don't think that there is a huge obstruction because the stone was completely packed up and it has dilated the whole PC system. The stone which we see in a UPJ obstruction are completely different varieties and the characteristic. This characteristic stone is not suggestive of a UPJ obstruction. It's a primary stone and the inflammation reaction that has led whatever narrowing is there. Can you see all the fragments even without adding a suction is coming out?
Yes, yes.
If you notice, most of the time my nephroscope is inside the sheath. The nearer the sheath towards the stone, the better would be the fragment clearance. Right? So if you notice continuously I am adjusting the nephroscope sheath under vision so that my stone, can you see I am rotating and allowing it to go?
Yes.
Pathetic. Pani. जायचं ना?
There is a question from the audience.
Yes.
Are you using accessory instrument like graspers?
See, why should I use the accessory? See, there is I have a 5 and 6 biprong, triprong, but I don't need to use it. And when you are trying to use an accessory, the size of the fragment that can come out would be small because that accessory's jaw would take up the space in the sheath. So if it is coming out without doing anything, why should I bother to use the forceps. See, that fragment was not falling, so I activated a suction. Right?
Yes.
Now I will not go further in, and I will try to break this stone. Right? Because it is at the infant. Right? So I will not go further in, but I will break here so that the stone falls. The job is you all repetitive movements. See the stone, break the stone. When you think that the stone sizes are smaller than the sheet size, you withdraw and remove whatever the fragments are there and repeat the procedure. So minimum instrumentations are required. Now there are a lot of fragments, I will take it out. So that fragment has fallen, now I will add a suction and it has came out, right?
Yes.
So if the fragment is falling back, then only I activate the suction, otherwise I don't activate the suction. The small suction, whatever is there, now you give me pneumatic. So breaking, withdrawing is a very simple task. He is doing wonderful job of holding the pneumatic in such a way that at the moment of my instruction, it comes and he just sticks. I don't have to change my vision. And what is the name? Sukumari. She is holding the sheath in such a way that I don't have to bother. She is allowing the scope movement like this, sheath movement, but she is not allowing the movement of the sheath to come out. So the assistant who is holding the sheath should allow the lateral movements, but not in and out movement. Because if she allows in and out movement, the sheath will come out, you will lose the track. And if she doesn't allow the movement, you will not be able to enter into different calysis. So she is doing wonderful job. Can you see so many fragments? This is not a vacuum cleaner effect, because the fragments are coming from far off and before it reaches there. See, I am just going advancing the sheet and they are coming out.
Sir, are you using any irrigation from ureteric catheter?
No. Right now, nothing. I'm not using a. I'm just using a gravity irrigation. No pump. Now, if I see, normally I use a multi-hole ureteric catheter, but it is not used. So, if you notice, a small fragment has gone down the ureter because of the irrigation. Have you noticed that?
Yes.
And if I use now I am entering that lower calyx, right? That my stone fragments. Before advancing the sheath, I am seeing that whether there is any other thing here, and then I am advancing the sheath by my gentle rotatory movement under vision, and I will take right up to the low calyx infundibulum mouth. So whatever the stone they are coming will not enter the pelvis, but will come out through the sheath, and it will not go down the ureter also. Can you see those secondary stones?
Yes.
And Badalo. Now, if the fragment is not, give me a pneumatic. It's the bigger stone. I need to break it. These are the secondary stones, infected secondary stones, which we were able to see, right?
So you want to use routine antibiotic if they are infected stones, or you want to increase?
Antibiotics are anyway required for all stone surgery, especially the infected. The issue was if there is an infected urine, should you continue or not? Now I am demonstrating that you can continue and completely clear all the infection. The treatment of infection is adequate drainage. No amount of antibiotic can help if there is adequate drainage is not established. By simply putting a stent, you can realize that everything is coming out very easily, right? Right? The system is clear, minimal edema in the system. So far, I have not used the forceps even once, right?
Yes.
Can you see? Because of the suction, these things were coming out. Now give me the pneumatic so that I can break this stone. For the first time, we have demonstrated ECIRS at advancement in embryology with Aditya, who is going to demonstrate ECRS now. You might be ready on the other side.
Okay.
And Ravi was demonstrating holding the flexible ureteroscope, and he was doing the from above. And because this Olympus has a unique feature that they can take two different things in a PIP, both of us were seeing in the same monitor, no separate monitors. Now, I need to use a forceps because I don't want to push my scope further down. Let's see if I can push through that lower calyceal infundibulum. I'll do that, otherwise I'll use a forceps, right? The suction will occur till the edge of the sheath. Can you see now? I have tried to go there, and now the thing would be much easier. Pneumatic. Now Rahul knows when I want a pneumatic and he immediately gives me. I don't have to say anything, it is always ready. I'll try to remove that first, because there are so many fragments. They will come out. I'll just have to advance slightly in. This is possible because I have taken upper calyceal puncture. Give me a force. See, now it has started coming.
What was the difficulty if you could have gone from the lower calyx or inferior
See,
calyx?
if those fragment has gone from lower calyx to upper calyx, the entry is difficult because in lower calyx I am going from posterior to anterior, and then from the pelvis to the upper calyx is again from anterior to posterior. So that is always a difficult job. See, all the fragments are coming beautifully without using any forceps because I advanced the sheath to
the
the
neck of the
infundibulum. Can you see all the fragments coming? Initially it was
yes.
seen three, only three. I had put a finger and therefore the stone which was falling back has come out.
Yes, yes.
The red cap suggests that you don't need to go further. Come, take out.
So how is this different from mini perk and standard nephroscopy?
The advance, yeah, I want a forceps. The difference is that I am using a different nephroscope and different sheath. I am using a different method of taking out the stone. I am using suction to take out the stone rather than the vacuum cleaner effect. Right? The
Yeah.
nephroscope is completely different nephroscope. And therefore I don't have to bother about the you realize that fragment, the forceps was, you have to orient in such a way that it can come out, otherwise it will not come out. Now I am just dropping, not taking out completely. Now this calyx is over, right?
Yeah.
Now there is another calyx where there is a stone and which is a bigger stone. Right? These secondary stones are coming out of its own with a suction and the fragments which has fallen. I am very happy with this demonstration also.
Hmm. Everybody is appreciating that also.
Thank you very much. Chhattisgarh workshop, Bilaspur workshop remembered for this also.
Sure.
And the credit goes to Prashant Mulakar also. He immediately said on advance when that Kaushik would give you a prime time to demonstrate your technique. So, lot of credits of bringing this to you. See, we were slightly reluctant to go for public demonstration, but then enthusiasm and the feedback and the encouragement we received. And special thanks to Dr. Kandar because it was he who said at the okay, bhai, I'll try my best to accommodate you, and he did that. He sent me his son that tell Kaushik if it is possible, we'll give it the next case, and we could demonstrate, and that improved our confidence.
Fantastic.
Give me pneumatic. Kandar, is he here?
Not now.
Where is he?
Must be.
I want
Gone.
to say a special thank. Today is very special day.
Yes, yes. We'll
No,
convey
other
your
is
message.
only Kandar knows.
We'll
I'll
convey.
tell him if he's here.
He might be in the operation theater.
I don't know. Let me share. When I was searching for a girl for marriage, I had given a PP number of Kandar, and he helped me a lot to find out a suitable girl, he and his wife. And today is my marriage anniversary.
Oh, congratulations.
Yeah.
There is a special message to you from Dr. Lal Manani that you are more happy today because you are alone.
No, she is there with me wherever I am. Wherever I am, she is with me. Kandar, thank you very much. Today is my marriage anniversary, and I shared that it is Kandar's phone number was a PP number for my matrimonial communications. And let me share another important thing that his wife Beena, when I said, "Ki bhai, I want to marry with Visakha," she said, "Don't ask anyone, just go and marry, it is my guarantee." So that's a great contribution of Kandarp in my life.
So nice.
Thank you very much.
Throughout the procedure, the vision is fantastic, absolutely clear.
Probably the dilated system has helped.
If the same system with a minipog, it would have been very difficult to bring out, because the system in minipog, what I have noticed, that the system should not be hydronephrotic. This is a very thin parenchyma. See, when the fragment is not coming, then only I am putting a finger. Otherwise, I am not putting my finger at all. Mandap, thank you very much for calling me on EIU that come here and demonstrate. That gave me a lot of confidence. Last few fragments remaining. Leader class is not working.
Dr.
This is
Kaushik,
probably the last fragment. You can continue whatever you want to say. It is not working. It wants me to say that you use a forceps.
There is a query from the audience.
Yeah.
Is this telescope made in India or?
This is manufactured in India. Chinmay and I are the innovators. We have applied for a patent also.
Okay.
This design we have patented. Can you show to Chinmay? Chinmay.
Is it rod lens or fiber optic?
Focus on him. See, when we were demonstrating this, he said that I want to make an endoscope. I said it is not our cup of tea. It requires a lot of investment, lot of technology. How he persisted, and
No,
I
is it
kept on helping him in whichever way. My role was facilitator rather than anything else.
Is it rod lens system or
No, it is a chip on tip.
chip on tip?
the other theater is also being ready in a short period of time.
Okay, you can go there, and whenever I'm finishing, I'll call you back.
Okay. Dr. Kamlesh, hello. Can somebody tell Dr. Kamlesh Maurya to present the case which is to be taken by Dr. Hiren? Hello.
Is the mic on?
Yes.
Good afternoon, sir.
Good afternoon.
Dr. Hiren Soda here.
Dr.
We are going
Parashar.
to, yeah, good afternoon. So we are going to start the RIRS.
Yeah.
It's a right RIRS. There is a stone in the upper calyx of the right kidney. Patient has been stented 1 week back. This is the X-ray. This is the CT scan. It's a 12 stone. That is the X-ray with the stone. Can you see there?
Not very clear.
Thoda defo.
Yes. Yes.
The stone is on top here,
Yes. Yes.
and that is the stent in place. And this is the CT. It's a 12 stone, about 600 Hounsfield units, stented 10 days back. So we are starting with the stent removal. Already the calibration has been discussed in the previous case. So I'm not doing ureteroscopy. I'll be putting the glide wire through the stent and directly access sheath, and we'll start. We are going to use the FlexX C flexible scope, because in the previous two cases they have demonstrated biorads, and also sir has used the UMD in the last case. So we are using a FlexX C. Patient is pre-stented.
Okay. So any second thought of going for upper calyceal puncture and doing PCNL, mini perk?
For this stone, no sir, definitely not. Just remove the stent till here only.
Yeah. That's why I asked. Now there is a question.
Yes sir.
On X-ray, it looks to be harder than what CT Hounsfield unit is.
Correct.
So we are keeping that point in mind.
No worries, we have a good powerful laser. Pani chalu karna. Fursa diya.
Yes. And those who are not gone for lunch, the lunch is going to be over within say 15 minutes. All those who are not gone for lunch, please.
Yes,
We had.
We had.
Gosh, thank you.
What are the differences between the other two and this flexible ureteroscope?
So this is the Karl Storz FlexX C, which is the digital scope by Karl Storz. Its size is 9 French, so definitely we need a 10 French access sheath.
Okay.
See,
And which laser we are using?
we are going to use a 35 watt thulium fiber laser. Sister Pakad. And we are going to use a 150 micron laser fiber, which is, I think, the first in India.
Dr. Hiren,
Yes, sir.
we would really appreciate if you can demonstrate how do you put in the access sheath.
Yes,
Because
sir.
in all these cases.
So, can you see this?
Yeah.
I put in the wire through the DJ stent. Now, because this ureter is already dilated with the DJ stent, we need not calibrate it. But normally, if the patient is not stented, then we should calibrate the ureter using a ureteroscope. So now we are going to directly use water, please. Water. Because these access sheets are hydrophilic, we need to lubricate them nicely. पानी चालू है दोनों? ये white निकाल के देना. नहीं, white वाला. Okay. So the setup is such that we can leave the guide wire here, and if we don't have an assistant, of course I'm honored and privileged to have Dr. Mulaukar sir with me. But normally, if there is no assistant, we can directly use the table, irrigate the access sheath. We should not remove the stillet because then a gap develops between the stillet and the access sheath. Sir, if you could support it. Jelly.
All of us are appreciating the untiring effort of Dr. Mulaukar. Since morning, he is continuously being
Yeah,
seen
really.
helping everybody.
We should thank him. So, Siam view, please. Can you see the Siam view?
No.
First, show how to hold the access sheath. This part of the access sheath needs to be held so that the stillet doesn't come out while inserting. And sir is holding the wire for me behind. And we are going now under fluorovision. And he is following, the Siam guy is following. And that's in the upper ureter. We should not go beyond this point because we may cause damage or perforation in the pelvis.
Okay.
So the first thing that I do while doing flexible is put this tip inside by the time you are making the connections. Can you pick up where is the Karlstorch?
In a pre-stented case, how frequently do you encounter? What is the incidence of you not be able to pass the access sheath in a pre-stented patient?
In a pre-stented patient, I think the best example is of AIE last that we attended, or many of us attended.
Yeah.
Kandra Parekh sir had pre-stented a patient, but then that patient's ureter was not dilated. So one in, I think, maybe 2 to 3% of such patients we may get nozzle, port seal.
Then how do you proceed then?
In that case, then you have to
Restent and wait for some time more.
Yeah. Or do a mini perk, I would say.
Can we wait
Sir,
for some
Harshvardhan
time?
here. Your experience of putting an access sheath with the use of 4.5 French ureteroscope, at times there are some kinks in there which will be easily negotiated if we put a sheath over 4.5 French ureteroscope.
No, I have never done it. I don't know if anybody does it also. 4.5 over the 4.5 ureteroscope.
Yeah, you have to backload the sheath.
it.
Yeah.
I have not done it. So what I do is I calibrate with a 6 7.5. If a 6 7.5 goes in nicely, then only use a 9.5 access sheath or a 10 French access sheath. But if you want to use a larger French access sheath, then a 8 ureteroscope should go in. So do you all have the endo view?
Yes.
Okay, you can see that there is a lot of dirty, turbid urine coming. And we are just about to enter the pelvic alytial system. And that is the stone. Okay. So now some important steps how to put in. You need to stabilize this port seal. So with your left hand you can stabilize the port seal, open it, and then insert the laser fiber. The person, can you cleave the fiber? Cut it with a scissor.
Whereas in this case, there is a lot of turbidity in urine.
Yeah.
You still want to proceed, or
I think that they have said that the culture is negative. I didn't see the report though. Yeah, and yeah, total flush, sir. Total flush.
suppose, sir, if culture is negative and still you found there is a lot of pus, at that time, what will you do? You will proceed, or you will just put a stent and come out?
I think that unless I see frank pus, I may just proceed because I don't know with a stent, if this has not cleared, I don't know how it is going to clear.
So in reality, in Indian scenario, how many of us are really looking for a culture negative and then only proceeding for RRS?
So we are practicing that. I think Kandar Parikh sir, myself, I think even Chandramohan sir is practicing that. We are doing cultures and mostly we are looking for negative cultures before proceeding.
It seems to be quite inflamed system.
Yeah, it is. It is. We'll have to be patient and give 5 minutes for it to completely stop oozing.
Do you have any second thought in your mind?
Sorry, sir?
Any second thought? Any change in plan?
No, I think we can proceed. It will settle down. This happens when Nanjappa sir was also started the case. It was initially oozy and then it settled down. Sir, can you irrigate a bit? Yeah. All okay? Anesthesia? Okay. Is there any problem? Everything okay? Ready.
Storage mid flexi.
Yeah. So can you look at the settings of the laser? We have got dusting with fragmentation. 0.1 and 150 hertz is the dusting, and 1 and 10 frequency is the fragmentation. Yeah. 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 Respiration is too much. Madam, all okay? बहुत ज़्यादा इधर respiration हो रहा है. हाँ. We'll wait for 2 minutes. They are just ventilating the patient.
So your take on use of Lasix preoperatively?
No, sir. I give it at the end, sir. I don't give it preoperatively. Can you see that there's a lot of deep ventilation that they are doing? So it's going and hitting the stone, even though I'm far away. Yeah. Yeah, this laser fiber comes at 9 o'clock position. Sorry, 3 o'clock position. In the FlexX 2S, it comes at 9 o'clock. So I showed in my presentation in the morning that somehow these companies have different position of the laser fibers.
In this case, the monitor is on the right side of the patient.
So I moved it there because I'm used to keeping the monitor only on one side. But like Kandar Parikh sir and even both Nanjappa sir said that you can have it on this side. It's what you're used to. I like the laser to be close to me and the CM on this side so that we don't have to keep on moving it in every case. But you can definitely have it here. You will not have to bend your neck.
While doing RRS, it's more useful to have a automated ventilation with the workstation.
Yes, definitely.
Than
We don't
the
have
hand
that.
ventilation.
Yeah.
Because the tidal volume is
Correct.
quite set.
Correct. We do that routinely, but here they don't have it. So since morning, all of us are working with the hand ventilating. Once they say that they are okay, we'll proceed. No, not required. You okay? Frequency 100 कर दो. Yeah. थोड़ा हाँ.
कोई बात नहीं.
Sir, we have lost your endo view. The next OT
Okay.
endo view is on.
Okay.
Hello.
Yeah.
Yes, I
Yeah.
have completed the things and the things are clear. Can you see the CM view?
No.
Uh, Connect to CM view. See, this is a complete clearance, right?
Yes.
Can you see everything is clear?
Yes. Yes.
I'll put a DJ stand and put an nephrostomy and come out. Okay?
Okay.
Okay.
Any specific reason to put nephrostomy also?
There is no specific reason. Sometimes I feel that if I have gone intercostal, I might put a nephrostomy for that tract to mature. Otherwise, it might leak into the pleural cavity. I'll just take a permission from Kamlesh what he exactly wants, because ultimately he has to see the patient. This was an infected system. There should not be leak of the system into the pleural space. Remove the ureteric. Remove the ureteric. Take it out. Take it. I am putting a DJ through this same channel, right?
Yes. We are switching to second theater, Dr. Kaushik.
I am putting right now DJ stand 5 French through that channel, and we'll decide with Kamlesh whether we want to put an nephrostomy or not. DJ
Yes.
stand is anyway required because it was an infected system. So we don't want to take a chance, particularly when we are done. Can you see the lower bladder?
So we enjoyed thoroughly.
Take it out. I enjoyed. Thank you very much.
Thank
Hello.
you.
Hey, let's go to RIRS again.
Yeah.
Please connect to other theater. Yes, Dr. Hiren, we are with you.
Yes, sir.
Hiren,
We are struggling a bit with the respiration. So I think it's moving a lot, but now they are giving it much better than before.
Hiren, how do you feel with this ureteroscope vis-a-vis UMD and Biorad?
Sir, of course, Carl Stores is standard, but I feel the new generation of Biored as well as UMD both are doing quite well. I just heard today somebody has used Biored for almost 84 cases. And we also saw it during the demonstration that Nanjapa sir did.
But this one you are using for the first time, no?
FlexXC I have used, sir, before. Yeah. Biored also I've used, and UMD also recently we used it.
Can I ask a question?
Yes, sir, please do.
Hiren,
Yes, sir.
Jackie here.
Yes, sir.
See, when we go to so many other centers where they do RRS,
Yes, sir.
particularly like RP Stone in
Yes, sir.
Gurgaon, you know, he insists on taking out each and every fragment with a basket.
Yes, sir.
I mean, we don't do that. And
Yes, sir.
do you
Most
think,
of us, sir, now we are using this dusting technique because sometimes in a large stone it becomes very taxing, sir, to take out each and every fragment. So if you are a little bit patient and do a good dusting, I think you will not have to do that. However, if the stone is small, 6 mm, 8 mm, it would be nice to just make it into 3, 4 pieces and fragments and then just take them out.
because he used to insist, he sometimes take 3 hours to remove 1.5 centimeter stone.
That
Because
also is
he used to
important, sir.
insist to take out every fragment.
Yeah, that is also important to reduce the time. Like Chandramohan sir was saying that, sometimes we are a little bit in a hurry and we do fragmentation and then popcorning. Many times I also do that, I don't have patience to do so much of dusting. Sometimes fragment it and then,
You sometimes have a bigger fragment behind all the dust.
yeah. That is why if you saw in the last case where Nanjapa sir was doing, I was not irrigating at all. Because sometimes all that dust flies and then you can't see if there are any fragments left behind.
You are using this one, the thulium. then you are likely to have little bigger pieces in this, no?
We are doing thulium only, sir.
So you will have bigger pieces. You will have to use.
I'm little careful in doing it as for, see, here is the dust. I'm going a bit slow because the respiration is on hand ventilation and not on a machine.
Hiren, what is the laser setting you are using?
Sir, right now we are in dusting of 0.1 and 100 and fragmentation of 110.
Intermittently pressing the foot switch, or is
I'm doing it intermittently because of the respiration, sir. I'm not able to go full speed.
Is that air bubble disturbing you?
Yes, it is.
How do you get rid of it?
We can't, sir. It is an anti-rec helix, I think.
Okay, you will have to be with.
Yeah.
With the previous laser machines,
Yes, sir.
it was necessary to remove the with baskets all the fragments and things like that,
Yes, sir.
because there was no laser which was giving the quality of dust which you get it now. So now with the changing scenario with the thulium fiber laser, and we have frequency of 200
Yes,
with
sir.
0.1, which is absolute dusting mode.
Correct,
And
sir.
at the end you find that the whole thing is dusted. Actually, there is no need of removing any fragment, because there will not be any fragments.
G.
And the other thing is that with the advent of the flexible disposable ureteroscopes, you can go actually inside the lower calyx without any problem. So relocation, which we used to advocate for lower calyxal stone in almost every conference, that also gradually disappearing. So need of basket actually is going down. That is how the cost of the overall procedure also is coming down, because however you may reuse it, these baskets are very delicate, 1.8 French basket. And if you use it once or even twice, they actually get damaged. So these baskets are not all that sturdy to be reused again and again, and it costs a lot. With the advent of thulium fiber laser, with the advent of now 150 micron fibers, which now we are using it frequently, the need for relocation of stone from lower calyx to other calyx is almost gone. And all these things actually have made the RIRS extremely cost effective procedure, which maybe 5 years back it was not at all. And therefore, with the changing scenario, a lot of things have changed in last 5 years.
Correct, sir.
Hiren, are you a little worried that you have done the center of the stone?
Sir, I'm trying to go towards the periphery and turn it around, but yet I don't have that much space. I will turn it around eventually. See, I'm getting there. So that I want to avoid the mucosa. As of now, I've avoided it well.
Can you try to pull out the stone with that fiber?
We can, sir, but then the chance of always breaking the fiber is there.
Are you happy with the dusting?
Yes, sir.
Still?
Yeah.
Sir, while doing such a large stone burden, is it necessary to intermittently check the outflow also?
Correct,
so
sir.
that at
We are doing
times-
that. If
Okay.
you can see,
Yes, sir.
cameraman, please. It's coming nicely in the access sheet. So my hand is continuously here.
Yes, sir.
I'm monitoring that. It is good, and plus Prashant sir is very gently, only when required is irrigating. And the amount of fluid that we have used in all the RRS since morning is only this much.
Kiran, you have the best
From the
assistant
audience, we
possible.
like to give a hats off to Dr. Prashant Mulawkar, sir.
Yes.
Thank
Since
you.
morning
Thank you.
is assisting.
You
Sir,
cannot
hats
have,
off, sir.
I'll give him a hug from all of you.
you cannot have a better assistant than the secretary of the society himself.
That shows how much he's interested in all of us and the academics. Hats off to sir.
But for the operator, it is embarrassing that your secretary is standing besides you.
It's also an honor, sir. We have
Hiren?
so much. Yes, sir. Please,
So
sir.
this the shell looks like calcium oxalate, but the center part looks different completely.
Yes, sir.
What
It's
is
a little
it is?
softish.
It's very softish,
I
more
think
like
I think this area has a lot of matrix here.
yeah, that's what I'm wondering because
Even
you can see
Chandra
the
Parekh sir,
laminations
yeah, it
on
looks
the
like
shell,
that, you know.
and you see suddenly some dirty muck-like thing in the
Yeah,
center.
it is. It is. That is why the urine was also like that.
Kiran, your access sheet appears to be quite outside. Is it a female patient?
Yes, sir.
So in this case, you are using 150 micron fiber or it's a 200 micron?
150, sir. 150.
So
First time.
with the same energy settings we can use, or there
Same,
are some-
same,
Yeah,
same.
150 micron, you use same energy setting.
And
no
he
problem.
just told me that you can give it as much energy as you want. Of course, we recommend not to go above 25, but the fiber can take it.
But now, next, they are going to come out with 100 micron fiber.
with those fibers, the maneuver will increase. Sir.
Yeah,
The
so it is like
flexibility will
putting a,
increase.
it is like putting a, yes, so this is also same 150. Once we say it is 365, it is almost 400. Once you say it is 150, it's a misnomer. It's a core, the coating which requires increases a little bit. But this advantage of this smaller fiber is that the flexibility of the scope with the fiber in position does not change. So that's a benefit. And of course, you get more space in the channel so that flow is better.
The laser has been used in small spurts, not continuously. Is it?
I'm doing it on purpose, sir. There is a lot of snowstorming effect, if you can see. I want to be safe. I don't want to be touching the mucosa or going through and making it into fragments.
And sir, using continuously lasers without giving rest, is it advisable, sir? Because
So we are intermittently stopping, right?
But the laser can take, there is no
It can be
problem.
used, yeah.
There is no problem. You don't have to stop in between. The lasers you can have continuous pressing of the pedal without any problem.
That is why Professor Traxier was saying again at the AIE, he was saying that there is no point having that much power and whatever frequency because you should be able to do it continuously. If you see, I'm doing it continuously, I'm just doing it on my experience. I'm not able to have a good vision as to, I'm there or not there.
That's because Prashant is not pushing at all.
No, sir, I told him not to.
You want to push the secretary, yeah. I think Ashish has described properly.
Prashant sir is getting hiccups now.
It's too much pushy.
Do we have any data or record highlighting the technical feasibility, like after how many cases your investment will be free? Do you have any idea?
No, it all depends. Actually, now if you see, we had done this calculation and we had actually one Zoom webinar on the cost effectiveness of flexible ureteroscopy and laser. you cannot calculate the machine to be becoming free because you don't calculate exactly. This is what calculations actually happen, the overall benefit to the hospital. If you see our experience of a robot for the, for example, anybody, per se, if you calculate the robotic surgery, it is not going to be cost viable. But it is an overall fulfillment of the institute where you keep getting other references also for the other surgeries, simply because they have the confidence that this center has everything. Similarly, once you have the flexible ureteroscopy and laser, with this disposable ureteroscope, using it multiple times, your cost of ureteroscope per se or per case, if you use it average 40 times, is only 2,000 rupees per case.
Okay.
So if you use 2,000 rupees per case, your cost of, and if you use 40 cases, your cost of disposable scope is gone. I mean, that becomes free. Laser fiber you use at so many places. You use for ureteroscopy, you use for flexible ureteroscopy, you use for PCNL. So it all depends on your overall workload. And the peculiarity of the thulium fiber is that it is the baseline basic investment, capital investment. After that, maintenance is hardly any. Your electric machinery, which is required for the holmium, high power holmium, if you take it, that changes are not required. Then the continuous AC, which are the costs which is involved in a high wattage holmium, is not required in thulium. It is portable. You can carry from one theater to other theater without any problem. So these are all other benefits of this in reducing the cost. So as I said, that disposable, flexible ureteroscope of Biorad, or for that matter anything, and the TFL actually has taken the advanced modality to a smaller hospital, to a smaller cities, to a taluka places, where even the non-affording patients now, with this gadgetry is available without compromising the profit per case what you are actually aiming for, because your cost has come down, expenses has come down. So if you consider that per case for as a surgeon or as a hospital of your nursing home, you require to earn X amount of profit, you can still earn that much because your expenses has come down, and therefore at a reduced cost to the patient, you are still at the benefit. So that is why these innovations are extremely important, because they have made the RIRS very cost beneficial, and therefore it has gone to the people who actually need it, who are non-affording.
Because previously it was available in larger centers.
Correct.
Now it's
So now that
percolating
is
to lower centers also, like with
100%, because you just have to have capital investment. Where the problem comes is recurring. In a smaller places, if there is some damage, if something is required, once the agent they sell the machine, they don't look at you. Then you have to be after them. Before buying machine, they are after you, but after buying machine, you have to be after them. So thing changes. And at a smaller place, they will always give time. This is not there, that is not there, and then your machine is stuck. Your investment is lying idle for those number of days, and therefore a machine which is less maintenance free, machine which has got only the capital cost, recurrent cost is not much. Like the other benefit of these disposable and a smaller fiber of TFL is that the baskets, your baskets and other things, the cost has come down. Otherwise, where are you? This is a recurrent cost. Every basket will cost 10,000 rupees. That also is an investment. If you don't have to use basket, if you don't have to use this 7.5 French scope, you can directly put it, or you can reuse the access sheet. Your cost has come down, so there is no problem.
Sapnes, I rather had a poor experience.
Of what?
Although I was using a flexible ureteroscope, my first FlexX2 lasted only about 26, 27 cases, although we were having a mentor also with me.
Yeah.
The second time I bought a FlexX2, it has now worked for about 40 cases. Already there are a lot of black dots. I used the Olympus. In 3 cases we had a problem, but it was a very, very
difficult case. And you are absolutely right. When you go and ask a company, can you repair this? Repair will cost 2 lakhs, 4 lakhs. Better you take in exchange.
Yeah.
So when somebody is saying that disposable one took 84 cases and still working, I think I would congratulate the person who is using that scope, because that is not as rosy a picture which
No,
I
no, but
saw
I'm telling
in
you,
reality.
see, you are using of Flexex 2 and other
Nahi,
things
nahi.
in which it will not last. I agree, fully agree with you. Even same experience with us, with multiple users, sometimes the residents, in the era of reusable ureteroscope with Flexex 2 and Olympus and other things, we were hesitant to give it to the residents for doing it. Every time we used to stand behind them. Every time there was a stone and the awkward moment, we would take over, because it was once damaged, it is
ये
5 lakhs
150
rupees are
वाला
gone.
फाइबर है ना
Whereas
ऐसे
now, with the disposable, reusable or whatever you call it, ureteroscope, the vision is good. It is not like Flexex 2 because it is a chip on the tip. Flexex 2, the problem is that even if you use very, very carefully, you are bound to get dots because fibers are going to get damaged. That doesn't happen in the disposable because it is a chip at the tip. So camera quality is better. The other big advantage of BioRad, what I am discussing from the scientific point of view, is that why there is a 4 hours and 8 hours and 6 hours and this light. Because if you have a LED inside the scope, it has got a life. It is bound to become dim, and therefore there is a cutoff of 4 hours or 6 hours, or various companies give. BioRad, why it is completely soakable, fully can be dipped because there is no LED inside. There is a light source which is there in the processor, and therefore they are confident. And we have used it. We have multiple users now. Our second year, third year residents are independently doing RRS. We don't even stand there because we are not worried about damage, and it doesn't get damaged simply because it is the chip and the tip. And light source doesn't get damaged
What
because
about the
it is a
diameter?
processor.
What about the diameter?
7.5.
Do you pre-stent when you use BioRad?
7.5 range, 7.5 range.
Only at the tip, though.
No, but even the shaft, it will go in 9.8 access sheath. What more you want? Absolutely no problem at all.
Jackie, even if you consider that you could do 26 cases, the money of the scope must have come out already. So even if you charge 10,000 per case, you have broken even. Exactly. So 26, you can use it for 10 cases and throw it out.
Sabnis, to corollary to you in Mumbai, now there are companies which are giving on hiring. So they will give you laser as well as they are giving you scope.
Okay.
And it is a fixed amount, like 15,000. If you are going to do multiple cases, they are reducing their charges. So now you know that this is a fixed expenditure you have to incur for the patient.
I see.
You
Okay.
just charge 12,000, 15,000
Right,
rupees extra.
right.
At the same time, there is one hospital where 4-5 urologists have come together and they have purchased. So even if your work is less, number of cases are more. with
Correct,
more people.
correct.
And then you can get the benefit.
See, our Flexex 2, with great care, with person dedicated for cleaning, washing, even only senior people using the scope with Flexex 2, our average use never went beyond 40. With the BioRad, with multiple rash use, with the residents using it, our average use is 48 cases. Last 3 cases, 3 BioRad 7.5 scope, average use is 48 cases. If you cross 40 cases, you are spending only 2,000 rupees per case.
That's very good.
And I'm telling you, this is not our experience. This is going to be experienced of almost everybody who is using it. Because light doesn't, the important thing is that light is in the processor. That's the biggest advantage. And therefore, it is completely soakable. You can dip into side X. Those who do not have steroid.
That's what I said. Somebody told me in the morning they've used for 84 cases. I was really shocked. BioRad's 84 cases is very good.
This is about the disposable
Dr.
scope.
Dr. Sabnis, can I make one comment on what you can I? Hello.
Yeah, go ahead, go ahead. We can hear
Doctor,
you.
are they with us?
Yes, we are
Yeah,
hearing
Dr.
you.
Sabnis?
Are you
Yeah,
there,
we are
sir?
hearing
Dr.
you.
Parikh sir wants to say something.
We can hear
दोनों mic
Kandap.
बंद कर
We
दिया.
can hear Kandap.
Dr. Sabnis, am I with the audience?
Yes.
I don't think so.
Yes, yes.
They are not able to hear us.
Dr. Sabnis?
Are we are able to hear you.
Yeah, too
No,
loud.
we can't hear you, sir.
Hello.
Hello.
I think from here the mic is cut off.
No, नहीं है connectivity. हाँ.
We are able to hear them, but they
Hello.
are not able to hear us.
Hello. Hello, Operation Theater. Can you hear us?
By that time, may I ask a
Uh,
question?
Hello.
Dr. Sabnis?
Hello.
Yes. Are we connected to the auditorium?
Yes.
Yes. Now we can hear you.
We are able to hear you, Kandap.
Yes, sir. Sir, so I just wanted to make one comment about the durability of a scope.
Yeah.
Now, as you said that FlexX 2S and even FlexX C, they, in my experience also, they do not last that long. They last about 50 to 70 cases max, and then we have to replace because it is not only the vision, but it is a deflection also, which is very important. And I think that is the first thing to go. Do you agree with me there, sir?
Absolutely, sir.
Okay.
Absolutely.
So it is not only the vision, because you might have few dots, but the important thing is the vision gets deteriorated as your number of cases increases. And secondly, it all depends on how many, what is the size of the stone you are dealing with. You know, if I have really my doubt when sometimes it is mentioned that the scope lasts for more than 100 cases or 200 cases when even with FlexX 2S and FlexX C, sometimes people do like 5 mm stone or 6 mm stone, and then they say that they consider that, yeah, my FlexX C has lasted for this many cases. I think it serves no purpose. If you take bigger size of stones, harder stone, complicated stones, lower chelicial stones, I think number of cases may be reduced to maybe 40, 50. Similar, the same thing happens with this all disposable scope. Second important thing is that what is your rationale? Do you want to just simply fragment the stone and then do a popcorning and call it a day? Or you want to produce a very fine dust where you really spend little more time in the operation theater? So durability of the scope depends on many factors other than only the expertise of a surgeon. I think that point also we should be considering because in my experience, even my disposable scope, like the limited use disposable scopes, they do not last for more than 15, 20 cases. When I have used both DIFRA as well as some other scopes, which are limited use scope. So I think we have to consider all these factors also into before
Yes, that is
stamping that these scopes last for this many cases. I think
yeah, that is absolutely true. What sort of cases are we doing? But by and
Yeah,
large,
I know.
when you do RIRS and when you see the stones, of course, yours is a referral center. You are doing very high volume work of RIRS. But by and large, in our institute, I don't know whether voice is going there.
yeah, sir, we can.
Institute, our restriction of the cases for RIRS is up to 1.5 centimeter stone. So our per case usage for RIRS is on an average is about half an hour or so, not more than that. Sometimes it is lesser than that if the smaller stones are there. So obviously, yes, it all depends on how long you are, rather than the number of cases, it is how many hours you have used that scope. That
Correct.
is very, very
Correct,
important,
correct.
which is absolutely true. But by and large, the indications, if we consider RIRS for average urologist, not the expert like you, is generally up to 1 to 1.5 centimeter stone,
Agreed, sir.
which does not take much time. And as I said, that with the thulium fiber, the rate of fragmentation and rate of formation of a dust is very, very fast. If there is any hard stones or anything, we actually, by choice, we go for PCNL, mini PCNL. So our institute basically is for PCNL, but our number of RIRS actually, because of this thulium
and the bioride is increasing for last 2 or 3 years. But I agree with your point that it is the number of hours which is very important rather than the number of cases.
And one more point I wanted to make that whenever somebody orders, because there are many people who are just starting RIRS, so when you order for this kind of a limited use ureteroscope, I think you should at least order for 2 or 3 available at one particular moment, because in this kind of a digital scope, it is all or none phenomenon. It is not like if the vision is gone, it is gone 100%. It is not like that vision will diminish over the period of time. If during the surgery only, supposing the vision is gone because either there is the time limit is over or whatever the cause, then I think you will have a completely blank vision and then you are in the middle of the case. So it is very, very important that you order, or at least you have 1 or 2 scopes in standby. That is also very, very important point.
Yes, I think Ashish has some questions.
Yeah, the question is to you or anybody in the house who could enlighten me. Whenever I've tried to ask the thulium vendors about what is the recurrent cost of the machine, what they have to say is nothing happens to this machine. Now it is a machine, something is going to happen to it over a period of time. Either it will deteriorate, its cell will deteriorate, or some component might go. They are not ready to give us the cost of the spares at the moment, nor are they telling us how many years the machine will last, though the warranty given by the company is 1 or 2 years. So does anybody have experience or anybody has data on this?
I can answer this question to you, Ashish. I think it's a very, very important point you have raised. And most of the times when you discuss with the company guys, I have discussed with majority of the people who are involved into the research of this thulium fiber, and most of the people do not have any answer, because the thulium fiber, it works on diode. There are 4 or 5 diodes. Yes, yes, yes. There are 4 or 5 diodes, and they are interconnected.
Dr.
And then
Kandab,
yeah.
little louder, please. There's some problem. We are hard of hearing you.
Okay.
Sound is not very good.
So thulium fiber, am I audible now?
Yeah.
Yes, better.
Yeah. So thulium fiber works on with the diodes. There are 4 or 5 diodes in the circuit. So suppose, and the diode has a very long life. So this is what the explanation they give, that the diode will last for a very long time. So there is no much maintenance problem. But suppose they don't have an answer whether you are in a position to replace one diode or not, because they are interconnected. And when I talk to some scientists, they said that if the diode is gone, you cannot replace individual diode. And then in that case, you have to change the entire circuit, and the changing the entire circuit costs as much as the cost of the machine, because the machine is only that circuit only. So then there is a problem. So we do not have a data of a machine which is, I think, more than 3, 4, 5 years old, because this technology was introduced in 2019. And so this problem remains to be answered, and nobody has a perfect answer. I think we have got Mr. Tyagi in the audience. If you can ask him that, because he represents IPG, probably he can answer, or maybe if somebody has a knowledge about it.
Yeah, I think what Ashish has asked is relevant, but as of today, the technology is such that we have no answer. Simply because you are right that machine is there, something is bound to go wrong. Nothing is going to be lifelong. But
So I
maximum
had
3 years now, the machine is working well, but at some point it is bound to get damaged, and we don't know what is going to happen. Neither the
No worries,
manufacturers know, or manufacturers probably will know, but they are not able to
Hard to
tell,
know.
or they don't want to tell, whatever is the reason. As of today, we don't know. But one thing is there, that it is maintenance free. That is quite a significant factor and
Sir.
significant cost saving.
Yes.
Subni sir, so I have
Yes. Yeah, we are
I was
watching
on
here.
yeah, I was quite on the surface of the stone, but as you see, many times towards the end, the shell breaks into multiple pieces. So now I'm going to use fragmentation as well as dusting combination, and it is quite a hard stone. It doesn't look like somebody correctly pointed out. It was not 564 Hounsfield units.
However dusting you do at the end, the fragments are bound to get formed. And I think that time you can do the popcorning.
Yes, sir, I'll do it now. Once it forms the fragments, I will do it.
Sir, is there any other modality other than hospital unit to identify hard stone or soft stone?
I don't think so.
Because in CT, as in this case, 600
Somebody
it is not
already judged
600.
on the X-ray.
It is on the
So in
appearance.
X-ray it is seeing
On the
very
the
hard
appearance,
stone.
you can see if it is a completely white, radio opaque, densely radio opaque, it is hard. If it is a porous, it is soft. And then when you actually go inside, many people judge that it is not a soft stone, it is a hard stone. So visual appearance, X-ray appearance, and the CT.
Correct.
Dr. Sabnis,
Yes.
can I make a point?
Yes.
See, the Hounsfield unit of the stone is quite arbitrary. It depends upon which area you are sampling. And whenever you are sampling a stone for HU, you are not sampling the complete stone.
Yeah, but they
You are
take
just
average
sampling
now.
the
That's
center,
the method of the CT people.
Yeah.
They take the average and they report in two ways. One is average and one is the center and the periphery. So this software they calculate.
Yeah. But still it is quite arbitrary. So it is possible to
I agree
have
with
a
you.
stone which is very hard, which looks soft on CT.
I agree.
It is also possible to have a stone which turns out to be soft, which you feel is
I
hard on
agree.
CT.
Totally agree.
Yeah. So for that, what we have to do is we have to ourselves sit on the console and
Hmm.
see the stone in different windows.
Ah.
Then only it is possible for us to judge how you are going to break the stone.
Right.
Now, suppose you put this stone on a bone window, you will find that sometimes the center of the stone is quite soft.
Hmm.
So which may not be picked up on by the radiologist because they do not see in so many windows. They just want to report the CT within 5 minutes.
Right.
Teleradiology.
Right.
Sabnis, although I made a comment about this looking harder than 600 units, to tell you honestly, after running a lithotripsy center, sometimes you see on X-ray, you feel the stone is extremely hard. And you give 1200, 1400 shocks,
Yeah,
stone has
correct.
disappeared completely.
Agree.
And sometimes you'll have a stone which looks pretty soft.
Yeah, yeah.
Okay, it's not that bad. Suddenly you'll end up giving 3 sittings.
Correct.
So things are really, really unpredictable.
Yeah, so that is really unpredictable. Agree.
Sapni sir, coming back to the use of a
Yeah.
disposable scope for the beginners. So earlier the disposable scopes used to be time bound, that biorad used to come with 30 hours. So what I used to practice is I used to switch on the scope once the excess sheath is in, everything is settled, and then only switch on the scope, go inside, finish. And one man used to switch off the scope immediately once you finish the dusting, because unknowingly we spent 10 minutes earlier and 10 minutes afterwards just keeping the scope dead there with the screen on. So we can save 20 minutes per case while practicing such thing.
Correct. I think Mr. Tyagi is here. So is there any, what is the company policy about the life of this machine and
User wala.
Yes, sir. Sir, actually, special concern about is the diodes which we
200
have
karna, 200.
in the machines. We have discussed several times with the company about the diode. They said, they are in the TFL technology almost last 20 years. So before coming to the medical, they are making as the same thulium fiber laser for industry also.
okay?
They said the source which we are supplying with the laser, which is basically having as a long life warranty in fact.
Okay.
So even last 20 years, even they have not faced any problems of the failure of the diode. With even not only for medical lasers, even they have not faced any problems with the industrial laser also. And where industrial lasers in the IPG concern about powers, like most of the industrial lasers, which most of the company manufacture maximum as a 2 kilowatt. But see, they starts from 2 kilowatt and they goes to the hundreds, thousands kilowatts machines. But see, they never attended any evidence of the failure of the diodes in the lasers. So that is the reasons which the laser same we are supplying to the markets. Even they don't recommend about the CMC of the equipment. They say the source which we are giving to the customer, which will having as a lifelong, the cycle of the product actually.
Okay.
Yeah. Thank you, sir.
Practically, they give a warranty of only 1 year. They
Sir,
should extend it for a
sir,
minimum.
actually, not only about warranty is the concern. Basically, of course, they have the limited warranty, maybe initially 1 year or 2 years warranty. It's all subjective things. But see, the machine needs to be as a proper maintenance, like the calibration will be required, So that is the reasons the company says that you can buy the machine with the warranty which they initially offers to the customer. But later on, at least you should have some like a nominal amount of the AMC so that engineer come and routinely and they can calibrate the machines, you know.
How frequently do you need?
Sir, basically, probably see any capital equipments or any electronical equipments which you are using in your operation theater, starting from as the, you know, the blood pressure monitors, every equipment need as a calibration, sir. So every capital equipment at least twice in a year, it should be as a calibrated, sir.
So if we look at the corollary, if a machine is requiring a maintenance every 6 months,
Suddenly उनके
that means there is
respiration
a
change हो
change
गया
in the
वापस.
machine, there is a deterioration in the machine.
See.
So it may not be appropriate to
How
say
much
that
it's
any
going in the
machine
laser
can be
fiber.
lifelong. Even the
See.
earth is not lifelong. It is
You
going
can
to
hear
be
it.
destroyed one day.
Ventilation.
Sir, I think you are right, even you know, but see specifically as the capital
Yeah, ऐसा
equipment
लग रहा है.
concern the life in the most of the
Can you
countries,
take it
they
behind?
minimum at least
Can you take
5
it?
years is the life of the capital equipments,
Behind,
you know.
behind.
But in India, you know, like there is no limitation. Sometimes there's a certain lasers which I have supplied personally about 15 years back and 20 years back and still the working. And specifically, you know, sir, in your case also, probably we supplied the machine about 15 years back and the machine is still as a working, you know. So like in India, it's entirely is a different definition, sir.
India, everybody wants lifelong.
Yes, sir.
So there is nothing lifelong in India except USI membership, which is lifetime. There is nothing lifelong.
Yeah, correct, sir. Thank you, sir.
Rest of the thing has life. Huh? We are trying to put the annual maintenance charge, which people are unhappy about it. Yeah. 31st? हाँ रजिस्ट्रेशन
वो बहुत ज्यादा कर रहे थे.
अभी 31st कहाँ आया है? जो 31st तक नहीं करते हैं वो और एक्सटेंडेड डेट में क्या करेंगे? ठीक है.
डॉक्टर हिरेन,
उसमें भी सबको लाइफ टाइम चाहिए, मेंबरशिप लाइफ टाइम चाहिए. So everybody wants lifetime free.
Dr. Hiren,
Yes, sir.
what is the plan now?
Now we are struggling a bit with the respiration. Suddenly there was a change of hand. It has become more labored. So I am now only dusting it, sir, with popcorning technique.
And followed by putting a stent and
Yes, sir.
call it a day.
Yes, sir. The main stone is completely broken, but now I need to just make it into fine dust.
So that is the whole thing. Kandap is there. So Kandap, this is what is the problem of the extended use of RIRS, where you take time and then respiration and other things. You keep spending a lot of time.
So there is no machine here. They are hand ventilating.
I know. I agree with you. But when you extend the indications of RIRS more than 2 centimeters, these are all inevitable problems.
Yes, sir.
Whichever setup you are
this is a hard stone.
Yeah, correct.
It looked
Accompanied by hard
like
stone and this.
564, but not at all.
And therefore, even though you have all this modern technology and other things, Miniperk still will play a role, especially in the when the time is a constraint and when you have. Sometimes people advocate 2-stage RIRS, you break it again, go it and is that. So I still feel RIRS has to be limited to a certain size of the stone where you are confident that it will be finished in a stipulated time.
Sabnis,
Yes.
Just Jackie again here.
Yes.
So can you please tell us what is this about Margaret Pearl, who says post PCN also 40% residual fragments? Is it that the Americans don't know how to do PCNL or we are better or what it is?
No, actually,
you have attended that meeting. You were there with me also.
Dr.
I know.
Sabnis.
Yes.
Just wait a minute. Before you answer that question, when we started doing PCNL, one anatomical abnormality of kidney was a contraindication for doing PCNL. Then slowly we graduated doing ectopic kidney PCNL, started doing horseshoe kidney PCNL. So RIRS will also graduate to that level that able to do lot many cases. But as of today, cannot say that you are extending the incision of indication of the procedure. I would not
Yes,
agree with
correct. See, Moravkar,
Yeah.
what we are saying is as of today, tomorrow we don't know what is going to happen. And therefore, in fact, if you see the evolution of the stone management, we never thought that the mini PCNL actually will go down and RIRS will take over for 1 centimeter or even 1.5 centimeter, but that is happening. Over a period of time, things are bound to change. Science is going to evolve. There are so many new things will come up. And what we are thinking today is the indication will become contraindication. What we are thinking today, contraindications are bound to become indications. So things are going to change. But in the today's scenario, as of today, with the whatever gadgetry machinery what we have, as of today, extending to 1.5 centimeter may be a little bit tricky. Rather than PCNL, mini pork will be better as of today.
Agree. I agree with you, sir.
So
It
Dr.
all depends
Hiren,
upon the expertise.
yeah, Dr. Hiren, very nice demonstration, difficult
Not only
case.
expertise, but we require the USI West Zone Secretary as a standby, sitting there. Pushy secretary.
बहुत movement हो रहा है.
No, but answering to what Jackie has come out, actually, that was a very important discussion which took place as to what is the residual fragment. And actually, answer to that is that if you keep doing, with what are you going to label it as a residual stone? With sonography and X-ray KUB, almost it is fallacious that you label it as the because so many millimeter stones will not be picked up and you will label it as a clear. If you consider the criteria of only ultrasonography and KUB. Now, if you keep doing CT scan in every case, then you will pick up a lot of so-called cleared cases has residual stones. Now, again, second thing in that is that on what day you do CT scan. If you do CT scan at the end of 24 hours, 48 hours, or if you want to do CT scan at the end of 1 month, there is a remarkable difference. So-called small fragments, residual stone up to millimeter, 3 millimeters, which you do CT scan before they are discharged and label it what exactly is the clearance. Now, if you do in all those cases CT scan at the end of 1 month, 80% of those so-called having residual stones actually are clear. So it all depends on when you do CT scan, when you label it as a clear, and even if you theoretically label it that there is a residual stone of 2 centimeter or 2 millimeter or 1 millimeter or something like that, it is statistically significant, but whether it is clinically relevant or not. Now, there is an interesting study of the 2 millimeter and 3 millimeter stone, which were picked up by CT scan after every case of RIRS or PCL, whatever you do, and they were followed up for 1 year, 2 year, 3 and 5 years. What actually happened to them, whether those stones grew or not. Over a period of time, less than 2 millimeter stone or 2 millimeter stone, 80 to 90% of them cleared up.
Hello.
Some stone, of course, they increase in the size. Some patients form the stone on the other side or other irrelevant thing. So it all depends on whether it is clinically relevant or not. Whether you want clearance,
Hello.
important from the clinical point of view, or from the investigation point of view.
Hello, sir. Yeah, we can hear you. Hello.
Sir,
Yeah.
if you can see, I
Kamlesh sir, can you hear me?
Yes, we can hear you. Which theater are we in?
We are with Dr. Hiren now.
Yeah, with Dr. Hiren.
Yes. Okay. Actually, I think
Excuse me.
Dr.
There is a-
Shabbir.
Yeah, before Dr. Shabbir starts, there
Yeah.
is a change of guard.
Sabnis.
Yeah, good evening, sir. Can you hear me?
Yes.
Yes, we are able to hear you.
Sir, we are shifting to other theater.
Okay.
Dr. Sabir Hussain is here.
Yeah,
He'll
wait
be
for a
demonstrating a PCNL.
yeah, wait for
with
2 minutes,
soft
please.
pulse.
Yeah.
Sir,
Before we start with Dr.
this,
Shabbir,
yeah. I request Dr. Ashish Patil, Dr. Rahul Bhargav, and Dr. Satyadev Sharma for moderation of next session. And Dr. Hiren, thank you very much for a nice demonstration.
Sir, who all are coming as a moderator?
if Dr. Rahul is not there, Dr. Shiven, please. Yeah. Dr. Jackie, sir, please come onto the stage. to give the mementos to Dr.
बेटा
Ajay
पहले
and Dr. Mandal.
आप यहाँ पर पहले फोकस करें. We will start with this.
Sir, I am handing over the mic to Dr. Shabir.
Hello. Hello, am I audible at audience?
So much.
Hello.
Dr. Shivain. Dr. Satya.
May I know who is moderating?
Yeah, this is Dr. Ashish Patil and Dr. Satyadev and Dr. Shivain.
Okay, okay. Dr. Ashish.
Hi. Good afternoon.
Good afternoon. The case which has been given to me, we can see in the first X-ray, this is the patient with the bilateral stones. Right side was operated a long back ago. And now we are having a stone on the left side, appears to be a staghorn infective stone. With, if you see carefully, there are multiple secondary stones in the upper calyx. And this is a CT which was done 1 year back probably, and which is showing a dilated, hugely dilated upper calyceal system with a multiple secondary calculi. And IVP practically is not showing any contrast on the left side, but they have done a DTPA which shows 20% function, and it needs to be preserved. So plan is to remove the stone, and I plan to remove the stone using the shock pulse lithotripsy, and let us see how it works.